Please all rise for the invocation, to be followed by the Philippine National Anthem, PMA, and PSA hymn.
Puso ko'y tinip ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Idalangin natin ang tapat sa may kapal, ay lunas sa lahat. Awit ng PMA, tayo ay mag-iwan, magtulungan, magunlad ng bayan. Ang kailangan, ibigay sa kanan, kalusugan at kasaganaan. Ang puso ko'y tigib ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Idalangin natin ang tapat sa may kapal, may lunas sa lahat. Idalangin natin ang tapat sa may kapal, may lunas sa lahat.
be seated. Okay, good afternoon, ladies and gentlemen, friends and colleagues. Let me introduce to you our Master of Ceremony. She is a Board of Director of the Philippine Society of Anesthesiology, Clinical Chair of the Department of Anesthesiology at Fatima University Medical Center, Valenzuela and Antipolo, the Vice President of the Philippine Society of Experimental and Clinical Pharmacology, a Commissioner of the Philippine Medical Association Commission on Continuing Professional Development. Likewise, an Associate Professor 3, Our Lady of Fatima University College of Medicine, and a past President of the Valenzuela City Medical Society. Let us all welcome Dr. Maria Janet Betita Serrano.
A pleasant good afternoon to all our fellow anesthesiologists. Today we are gathered here to listen and learn from the different cases encountered by our colleagues. To welcome all of us, I would like to call on the President of the Philippine Society of Anesthesiologists. He's also a former chair of the Department of Anesthesiology of Asian Hospital and Medical Center. He is the past president of Society for Obstetric Anesthesia of the Philippines and also an associate professor of the Department of Anesthesiology of the University of the Philippines, Philippine General Hospital. Let us all welcome our president, Dr. Edgard M. Simon.
Good afternoon to everyone. So we are now going back to normal. I said this because using the road is again a challenge. I'm already on my way, but I decided to make a U-turn and went back home instead because I'm afraid I cannot reach the venue on time. Someone even texted me, ibalik ang lockdown. She found herself stuck in EDSA. I hope she was able to make it. So to start this activity, I'd like to extend my warmest welcome to all our colleagues and members of PSA, our esteemed judges, and our contestants. We are celebrating the entire week as Anesthesia Week. The World Anesthesia Day, which we celebrated a week ago, commemorates the birth of anesthesia on the 16th of October, 1846, when William T.G. Morton demonstrated the use of ether for the first time on a patient at Massachusetts General Hospital. This week has been a very busy week for everyone. Our national chapter scheduled a week-long activity of academic and non-academic activities. And our local chapters also had their celebrations that included lectures and social activities. PSA Mindanao had an evening of fun with their search for Mr. and Miss PSA Mindanao. Today's interesting case presentation is the culmination of our Anesthesia Week celebration. And I would like to congratulate all our contestants for participating in this contest. An important tool of medical education and inpatient care. The cases that you will be presenting today will make a meaningful contribution to the rapidly expanding knowledge and education of our residents as well as our specialists in anesthesia. So as our way of acknowledging your contribution to the education of our members, I'd like to announce that the PSA board decided to increase the prices for our winners as well as consolation prizes for the rest of the contestants. So I'd like to take this opportunity also to announce that we extended the COVID Mutual Aid Fund for members in good standing who had COVID, either hospitalized or on isolation until December 31, 2021. So to date, we have already released more than 1.5 million to our members who had the disease. So I'd like to say congratulations again to our contestants and good day to everyone.
Thank you, Dr. Simon, for that very warm welcome. The selected cases for this contest underwent a very rigid process before your case was chosen. In fact, there were around more than 42 cases that were submitted for this year's contest alone. Let us welcome one of the members of the Philippine Society of Anesthesiology Continuing Medical Education Subcommittee on Interesting Case Contest to give us the contest mechanics. He is also a PSA board director and a board member of the Philippine Board of Pain Medicine. He is the assistant head of the Pain Management Center of St. Luke's Medical Center in Quezon City. He's also the vice president of the Philippine Society of Oncology. Just like our president, he is also an associate professor as well as the chairman of the Department of Physiology of the Pamantasan ng Lungsod ng Maynila College of Medicine. Let us now call on Dr. Salvador E. Brodit Jr.
Okay, good afternoon, contestants, friends, colleagues. I would be presenting the 30th Interesting Case Presentation Competition Oral Presentation Mechanics. So each participant will be given 8 minutes to present the interesting case report, beginning from the start of the audio narration until the end of the presentation. A deduction of 0.5 points from the total score will be given for every minute in excess of the allocated time. An open forum will follow after the 5th and then the 10th presenter. Only members of the Board of Judges will be allowed to ask questions. The participant must be in proper business attire and white blazer during the open forum. Participants who fail to comply will be given a deduction of 5 points from their total score. By the way, when you present here, you are allowed not to wear your mask, because you're far away from everyone else anyway. The criteria for judging will be as follows. A, manuscript, 70%, wherein there's a clarity of report, 10%, which comprise the overall clarity and conciseness. Importance of the case, another 10%, wherein there's the author's statement regarding rarity of the disease, uniqueness of its presentation, and or importance in clinical practice. 3, volume of work, 25%, which pertains to completeness of work, documentation, follow-up, and outcomes. 4, scientific discussion, which is also 25%, which pertains to the strengths and limitations associated with the case, relevant medical literature with references, rationale for conclusions, and primary takeaway lessons of the case report. So for the oral presentation, which is 30%, manner of presentation is 10%, visual aids is 10%, and open forum, wherein you answer the questions, 10%. The decision of the Board of Judges is final and irrevocable. Okay, now we go to the prizes. No? As Dr. Ed Simon already told you, I think this is a good news. So the first place, from 20,000, it is now 25,000 and a plaque of recognition. Second place, 15,000 and a plaque of recognition. Third place, 10,000 and a plaque of recognition. For the consolation prizes, previously I think it was 3,000, but now it's 5,000 and a certificate of participation. So you will not go home empty-handed. Okay? So with that, thank you very much, Dr. Rejani.
Thank you, Dr. Brodit. Now, the winners of today's contest will be assessed and decided upon by a distinguished board of judges. The one who will introduce them is none other than our very own PSA Vice President, who is also the chair of the PSA CME Subcommittee on Interesting Case Contest. She is the chief and head of the Fellowship Program, Division of Regional Anesthesia of UP-PGH, and head of the Academic Committee of the Manila Academy of Regional Anesthesia, or MARA. Also, she is an anesthesiology consultant of Asian Hospital and Medical Center. Please welcome Dr. Penafrancia C. Cano.
Good afternoon, everyone. I'm so honored to introduce the members of the Board of Judges. So the first judge for today's contest is a graduate of the UP College of Medicine. She took her residency training in anesthesiology also at the University of the Philippines, Philippine General Hospital. She was actually a senior of mine when I had my residency. She also has a master's in clinical epidemiology, which she took at the University of the Philippines College of Medicine. She's also an assistant professor at the College of Medicine of New Era University, and she's presently the assistant head of the Department of Anesthesiology of the Veterans Memorial Medical Center. Friends and colleagues, let us welcome Dr. Noemi Bensuceso. The second member of the Board of Judges took her residency training in anesthesiology at the De La Salle University Medical Center. She holds a master's in management in hospital administration from the Philippine Christian University. She is presently the chair of the De La Salle University Department of Anesthesiology, and she is also an associate professor at the De La Salle Medical and Health Sciences Institute, College of Medicine. She is also the past president of the Philippine Society of Anesthesiologists, Southern Tagalog Chapter. Friends and colleagues, let us welcome Dr. Violeta Duldulao. The head of the Board of Judges took her residency training in anesthesiology of the University of the Philippines, Philippine General Hospital. She was actually my batchmate. She took her fellowship in pain management in India. She also had a preceptorship in ultrasound-guided regional anesthesia in Germany. She holds a master's degree in health services administration from the Ateneo Graduate School of Business in Makati. She also holds a master's degree in clinical epidemiology, which she took from the University of the Philippines in Manila. And she recently had her PhD in educational management from the De La Salle Araneta University in Malabon City. Presently, she is the chairman and associate professor at the Department of Anesthesiology of the College of Medicine at the Our Lady of Fatima University in Valenzuela City. She is also the research coordinator at the Department of Anesthesiology of the V. Luna Medical Center, Quezon City. She's really a very busy person. Aside from that, she's also the head of the pain clinic of the Department of Anesthesia at the Fatima University Medical Center in Valenzuela City. She's also a pain consultant at the Department of Anesthesia at the Adventist Manila Medical Center. And she's also the department manager, Education and Training Department at the Lung Center of the Philippines. She's a board member of the Asian-Australasian Regional Section of the World Federation Society of Anesthesiologists, and she's the past president of the Philippine Society of Anesthesiologists. Friends and colleagues, let us welcome Dr. Sinaida Mariano.
Thank you, Dr. Cano. All right, so let's now proceed to the contest proper. Are we ready? The first case is a case report on airway management of a pediatric patient with ankyloblepharon ectodermal dysplasia clefting, AEC syndrome, using two-stage styles technique. May we hear from Dr. Michael Ryan A. Manera.
When confronted with rare and compromised airway, it is of critical importance that we recognize this in the management of our subject. But what if you're presented with a patient with no mouth opening? Good day, I am Michael Manera and I will discuss the airway management of a pediatric patient with ankyloblepharon ectodermal dysplasia clefting syndrome using two-stage styles technique. Our patient is RH, a 1-year and 6-month-old female with a chief complaint of multiple congenital anomalies. She was born to a then 30-year-old, term pregnancy via repeat cesarean section, and upon birth, patient presented with cleft lip and palate, no mouth opening, bilateral ankyloblepharon, and hyperpigmented lesions on both lower extremities. Mother uses a specialized feeding tube that she will insert on the left side of the mouth to feed the patient. Cranial CT scan and 2D echo were requested, which were unremarkable. Initial assessment was AEC syndrome on the basis of a history of ankyloblepharon and features like flat nasal bridge, hyperthaloric eyes, wide nasal base, flat midface, unilateral cleft lip and palate with bilateral camptodactyly and hyperpigmented lesions on both lower extremities. Preoperative assessment was done prior to surgery. Vital signs were within normal values. Salient airway and head and neck physical examination include craniofacial anomalies such as unilateral right cleft lip and palate, short chin, and no mouth opening. Coordination with different services like ORL and pediatrics was done due to a likelihood of tracheostomy because of the possibility of a difficult airway. On the day of surgery, preoperative vital signs were normal. Everyone in the team made sure that every equipment needed during the induction were available and functioning well. Pre-oxygenation via a modified pediatric high-humidity GA mask was done for 5 minutes. Atropine, 0.2 milligrams, and midazolam, 0.5 milligrams were administered. Lidocaine, 10%, and oxymetazoline spray were given to help in decreasing the nasal mucosal vascularity. The fiber optic scope was inserted in the left nostril and was carefully guided down and the tip positioned at the level of the vocal cords. This is the actual video of the fiber optic intubation of the case. Guide wire was inserted into the suction channel and is advanced into the trachea. After the glottic opening was visualized, the fiber scope was then removed, leaving the guide wire inside the trachea, and then a suction catheter was advanced over the guide wire into the trachea. North tube size 4 was threaded into the trachea, and tidal capnography and listening for clear and equal bilateral breath sounds were done to ensure proper placement of the tube. A total bolus of 40 milligrams of ketamine IV was given for sedation during the intubation. A portion of the mandibular coronoid had to be removed for intraoperative findings of TMJ ankylosis. This is a real recording of the conversion from nasotracheal to orotracheal intubation using south tube size 4 under videolaryngoscopy. This was done to facilitate bilateral chyloplasty and tajima rhinoplasty with repair of lower lip pits. Intraoperative findings were intraoral upper and lower bands, upper and lower lip pits, and a mouth opening, which started preoperatively from 0 centimeter to 3.5 centimeters after the release. Patient tolerated the procedure well, and the patient was extubated fully awake. Patient was then transferred to the post-anesthesia care unit stable with no critical events noted. This is a photo of the patient on her first post-operative day. On post-operative day 6, removal of sutures was done and dry well coaptated wound was appreciated. Patient was discharged on post-operative day 10. What is AEC syndrome? AEC, or Haywell syndrome, is a rare autosomal dominant genetic disease. Diagnosis is clinical. Genetic testing may be done to ascertain the diagnosis, which shows that this is often the result from the heterozygous missense mutation in the P63 gene, which is important in limb, craniofacial, and limb development. Treatment is directed towards the specific symptoms that are apparent in the individual. Ankyloblepharon is limited to small bands of vascularized connective tissue that are spanning the eyelids. And this is the classical feature that distinguishes AEC syndrome from other disorders that will also present with ectodermal dysplasia and cleft lip or palate. According to the National Organization for Rare Disorders, its exact incidence and prevalence is still unknown. It is considered as an extremely rare disorder, and fewer than 100 affected individuals have been described in medical literature. For the benefit of time, I've condensed our anesthetic issues and problems into a AAA, which stands for airway, anesthesia, and anticipated future problems. Notice that they are interconnected because of the importance of each to one another. Let's start with airway. TMJ ankylosis management presents a formidable challenge in the maintenance of airway patency. Inability to open one's mouth makes direct laryngoscopy impossible. In a review by Wahal et al., they affirmed that fiber optic intubation is the gold standard for these patients. And when this fails, the only option left is tracheostomy, because of the superimposed difficulties of a pediatric airway, both anatomically and physiologically. Ovasapien mentioned that if fiber optic exposure of the larynx proves difficult or requires extra time, the use of an endoscopy mask provides the option of ventilating the patient during intubation, and this is the valuable feature that is lacking in most other intubation techniques. So, in a nutshell, two-stage styles technique comprises of the fiber scope being positioned at the level of the vocal cords, then the guide wire being advanced into the trachea, after which the fiber scope will be removed, leaving the guide wire in place, and then the catheter will be advanced over the guide wire into the trachea, and then the tube will be threaded over the guide wire and the catheter into the trachea. Lastly, the catheter and the guide wire will be removed, leaving the endotracheal tube in place. So why was this used? The use of a fiber optic scope to pass an endotracheal tube is impossible to follow for intubating patients, since the smallest internal diameter that would easily slip over the guide would be a size 6. In our patient, the tube that was used was a size 4. This has been used as a basis for the intubation of our patient, and no literature has been written so far that utilizes this technique in intubation of pediatric patients with AEC syndrome presenting with TMJ ankylosis. The anesthesia machine was prepared by flushing oxygen overnight due to the risk of malignant hyperthermia. Ergo, TIVA was then initiated with propofol infusion. As mentioned, capnography was used and precordial stethoscope was placed. Anticipated future problems were managed through strengthening of perioral muscles, language stimulation, and oral feeding, hence the referral to rehabilitation services. Patient is continuously being followed up by plastic surgery for contemplated palatoplasty. In case you are wondering, here are the recent photos of our patient. 6 months post-operatively, mother verbalized that feeding has already improved and patient can already babble syllables. She also has regular follow-up with pediatric genetics and plastic surgery. Started from no mouth opening, and now a glimmer of hope through a beautiful smile. In conclusion, two-stage styles technique is a viable option for airway management of these patients, and it is a safe technique to be used for patients with AEC syndrome for surgery under general anesthesia. Here are my references, and thank you very much.
Thank you, Dr. Manera. Our second case is entitled Retrograde Intubation in a Patient with Oral Squamous Cell Carcinoma, a case report. Let us all welcome Dr. Jaira Gail D. Baluga.
The major responsibility of the anesthesiologist is to secure the airway and provide adequate ventilation to the anesthetized patient. Inability to manage a difficult airway has been responsible for death attributable to anesthesia. Therefore, a good clinical judgment is important for selecting the method for airway intervention. Good afternoon, I'm Jaira Gil Baluga and here to present a case report on retrograde intubation in a patient with oral squamous cell carcinoma. We are presented with a 43-year-old male, farmer, Filipino, married, who came in with a chief complaint of an open wound in the right buccal and lateral neck area. 9 months prior to admission, there was a noted right retromolar trigone ulceration with associated toothache. Patient went for a dental consultation wherein tooth extraction and dental biopsy was done, revealing squamous cell carcinoma. However, the patient was lost to follow-up and interim showed rapid enlargement of the mass extending up to the buccal mucosa and overlying skin. Until 1 month prior to admission, spontaneous tumor bleed was noted, sought consult at another institution and underwent emergency commando procedure with reconstruction using pectoralis major and sternocleidomastoid flap. 5 days post-op, flap necrosis was noted and antibiotic was continued, but no noted changes. Was then referred to this institution for debrima and reconstruction, hence admission. Past medical and family history were unremarkable, while social and environmental history pointed to a smoking of 2.5 pack years and 20 years of betel nut chewing. The patient was conscious, coherent, not in cardiopulmonary distress with the following vital signs. He was cachectic with an essentially normal cardiopulmonary findings. An open wound was noted over the operative site on the right zygomaticobuccal area with extension to the lateral lip commissure of the supraclavicular area down to the anterolateral neck. From the preauricular area, the open wound extended inferiorly to the posterolateral neck with partial exposure of the anterior trapezius muscle. The surgical incision site of the pectoralis major myocutaneous flap can also be seen at the anterior thoracic wall of the patient, well coaptated with no bleeding nor discharges. Seen attached by sutures at the superior edge of the operative site was the now necrosed flap with minimal clear to yellowish discharge but with no bleeding. The lateral neck muscles and the oral cavity were exposed by the defect. A 1 by 1 centimeter firm, non-tender, irregularly bordered solid mass was noted at the submental area with multiple palpable nodules at level 2, 3, 4 of the contralateral neck. The patient had a malampathic class 3, mouth opening of 2 finger breadths, a thyromental distance of less than 6 centimeters, and there was noted limited neck extension. Preoperative laboratory tests done were unremarkable except for hemoglobin of 101 grams per liter and hematocrit of 0.30. Diagnostic imaging done to the patient had the following results. Given the condition, the patient was scheduled for modified neck dissection right with reconstruction of lateral neck and buccal defect and referred to the department for anesthesia care. The patient presented with airway management difficulties due to restricted mouth opening, limited neck extension, and malampathy score of 3. A difficult direct laryngoscopy was expected. The open wound at the buccal and lateral neck meant bag mask ventilation would be impossible and supraglottic airway device would not conform to the altered anatomy of the airway. Also, surgeons request that a tracheostomy be the last resort to secure the airway added to the dilemma. A tracheostomy would block the contralateral flap expected to cover the defect, making the contemplated surgery a failure. The ASA difficult airway algorithm suggests that difficult cases should be assessed for ease of mask ventilation, ease of intubation, and ease of direct tracheal access. In this case, all 3 routes were anticipated to be difficult and nearly impossible. Therefore, an awake intubation was thus warranted. During awake intubation, the airway can be secured by non-invasive intubation and by invasive airway access. So we secured consent for an anesthetic plan of general endotracheal anesthesia via invasive airway access using retrograde intubation. Success of an awake intubation is dependent on proper patient preparation. Emphasis is put on the crucial role of psychologic preparation for the success of the procedure. The extensive explanation given preoperatively on the steps to be done and why it is done made the procedure bearable for the patient. Also, anxiolysis with midazolam and airway topical analgesia with lidocaine spray given prior to intubation complemented the above strategy. The patient was received at the operating room and standard ASA monitors were attached with the following baseline vital signs. Materials were prepared, and after pre-medication, the patient's airway was anesthetized with lidocaine spray. The cricothyroid membrane was identified and a two-way needle gauge 18 was gradually inserted to gain access via loss of resistance to air technique. An epidural catheter was then inserted and advanced towards the oral cavity. The catheter was then secured to the distal end of a size 7 armored tube and the tube was gradually inserted into the oral cavity. While the patient was being instructed to swallow, resistance was met when the tip of the tube was at the level of the cricothyroid membrane, then the tube was gently advanced distally. Placement was confirmed by capnography and patient was then induced. Anesthesia was maintained with oxygen and sevoflurane, and operation was unremarkable and lasted for 9 hours and 50 minutes. Post-operatively, the patient was transported to PACO with stable vital signs and spontaneous breathing. He was extubated 40 hours post-op without complications and was sent home recovered after 62 hospital days. Retrograde intubation is a well-known alternative for securing the airway where intubation is unsuccessful but ventilation is possible, and it was first described by Butler and Cirillo in a neck surgery way back in 1960. Our patient's airway was secured based on the technique by Waters, where he passed a plastic tube as guide for intubation through the cricothyroid membrane. Waters' technique has the advantage of having less chance of bleeding, subglottic edema, and stenosis. It can be used in awake, obtunded, or comatose patients who have an anticipated difficult airway and is also used as an alternative to fiber optic intubation due to non-availability of the latter. Due to unavailability of retrograde intubation set, we used an epidural set gauge 18, which was readily available in our institution. Our tube passed successfully at the very first attempt, confirming the findings of Wexler et al. That retrograde intubation is a minimally invasive airway management technique with a flat learning curve and a high level of skill retention. In a study by Van Stralen et al., where emergency caregivers were taught retrograde intubation via modeling, they reported that retrograde intubation on a mannequin required a mean time of 70 seconds. Namatsi et al. Have shown that the advantages of retrograde intubation lie in it being safe, simple, and effective technique in managing a difficult airway. It is less invasive, good choice for patients with altered airway anatomy, and lastly, retrograde intubation can be successfully performed in the presence of blood or secretions in the upper airway. As anesthesiologists, we must not be afraid to explore different modalities in managing a difficult airway. Being an anesthesiologist requires critical thinking and continuous sharpening of skills amidst the limited resources we are faced with. I therefore conclude that the retrograde intubation is a suitable and safe alternative to secure the airway of our patients with altered airway anatomy. Thank you and God bless.
Okay, our third interesting case is entitled Complexities in its Rarity, a case report of a fast-growing mesenteric mass in a pediatric patient complicated with renal agenesis and congenital heart disease. May I call on Dr. Jordan Carl Pervera.
Good afternoon, doctors. I'm here to share with you the story of how we manage a complex case of a pediatric patient with multiple comorbidities. Anesthesia for children is challenging in itself. Here we are presented with a pediatric patient with a large intra-abdominal mass for resection, complicated with congenital heart defect and unilateral renal agenesis. Mesenteric cyst is a rare abdominal disease, commonly presenting as abdominal swelling, pain, early satiety, and at times an acute abdomen. Incidence is 1 in every 100,000 births in the US, and in the Philippines, incidence is not clearly documented. Congenital heart disease is the most common birth defect, and 20,000 babies are born per year with this condition in our country. This is a case of a 4-year-old male patient, previously well with a chief complaint of a rapidly enlarging abdomen. 2 months prior to admission, the patient initially presented with abdominal pain associated with fever, vomiting, and weight loss. He was treated for amoebiasis, however, there were persistence of symptoms, eventually being associated with bipedal edema and a progressively enlarging abdomen. Patient was admitted at another institution where echocardiography revealed a perimembranous ventricular septal defect with left to right shunting and mild to moderate mitral and tricuspid regurgitations. Left ventricular ejection fraction is preserved. CT scan, on the other hand, revealed a large renal cyst on the left. Patient was advised to undergo nephrectomy, hence transfer to our institution. Preoperative visit showed a conscious but weak-looking and cachectic child with the following vital signs and anthropometric measurements. Subcostal retractions were appreciated along with a grade 3 holosystolic murmur. The abdomen was distended to a circumference of 57 centimeters but was non-tender. At the time of visit, no edema of the lower extremities was seen. Laboratory findings were as follows. Creatinine and albumin were decreased, which is consistent with malnutrition. A CT urogram was also done, which showed an abdominopelvic mass and a non-visualized left kidney. Working impression at the time was renal cyst versus mesenteric cyst, renal agenesis left, congenital heart disease, ASA 3, Malampati 1. Surgical plan was to do cystoscopy with retrograde pyelogram to rule out a right renal mass. Then proceed to an exploratory laparotomy if the right kidney was revealed to be normal or if there is resectable renal mass. Anesthesia plan was general endotracheal anesthesia. At this time, we were faced with confluence of problems, complicating an already complex case of management of a pediatric patient. One of the difficulties we were facing was malnutrition, which is associated with increased perioperative complications and prolonged hospital stay. Nutritional buildup with parenteral nutrition 7 to 10 days prior to surgery is said to contribute positively to clinical outcomes. Unilateral renal agenesis is another concern as it highlights the importance of maintaining adequate renal perfusion to prevent acute tubular necrosis and damage of the remaining normal kidneys. Further complicating the case is the patient's ventricular septal defect with mitral and tricuspid regurgitation. Although ejection fraction was normal, it was essential to maintain adequate left ventricular function and prevent hemodynamic instability and increases in shunt fraction. Finally, the presence of a large abdominal mass may affect a multitude of organ systems. Lung capacities and cardiac output are decreased due to mass effect. During resection, decompression of the abdomen may cause fluid shifts, while adhesions to neighboring structures can complicate the surgery and increase blood loss, ultimately making hemodynamic resuscitation more challenging. The patient was admitted under urology service and referred to pediatric cardiology and pediatric surgery. The relatives were advised of the surgical and anesthetic plan and were well appraised of the possible risk and complications. Nutritional buildup with enteral and parenteral feeding was started upon admission for 2 weeks, and on the day of the procedure, intravenous lines were secured, blood products were confirmed to be available, and vasopressors and inotropes were prepared and computed ahead of time. On the day of surgery, the patient was brought to the operating room awake, not in distress, and he was placed in semi-Fowler's position to optimize pulmonary function and lengthen safe apnea period. Monitors were hooked and BP was noted to be elevated, while other vital signs were within normal range. Preloading was done, then we proceeded with induction using the following agents. Of note is the use of fentanyl, which was used not only to aid in laryngoscopy, but also to decrease left ventricular stroke work, which is especially important in patients with cardiovascular problems. Intubation was then done using a video laryngoscope with Macintosh 1 blade and a cuff endotracheal tube. A right IJ catheter was inserted post-induction, and the patient was maintained with sevoflurane, fentanyl, and rocuronium. Many different anesthetic techniques have been described, but there is little evidence to recommend one technique over another. Gaseous induction with sevoflurane is the most common in pediatric practice and can be used for children with congenital heart disease because of its minimal effect on myocardial contractility and shunt fraction. In addition, normothermia was maintained with a forced air warming device. Cystoscopy with retrograde pyelogram confirmed left renal agenesis and no renal mass. Bilateral ureteral stent insertion was done, and pediatric surgery proceeded to exploratory laparotomy. Vital and clinical signs with fluid input and output monitoring was done. We anticipated the possibility of fluid overload. Thus, fluid resuscitation was goal-directed. During decompression and resection, the butamine drip was started after note of episodes of hypotension, despite adequate fluid infusion. Blood transfusion was initiated to replace acute blood loss, but dopamine and epinephrine drips was attained by continuous fluid resuscitation and careful titration of these agents. Surgery revealed left renal agenesis and a cystic mesenteric mass adherent to the mid-transverse colon and the pancreas with 2.5 liters of serous fluid drained. Postoperatively, vital signs were noted to be stable as follows. Epinephrine and dobutamine drips were already discontinued towards the end of the procedure, while dopamine drip was slowly down-titrated and eventually discontinued 1 hour post-op. Patient was transferred intubated to the pediatric surgical ICU, and paracetamol and fentanyl drip was given for pain and sedation while on mechanical ventilation. The patient was then eventually extubated on the second post-operative day and discharged well and improved on the 97th hospital day. The case we handled was complex and challenging due to the intricacies which we had to take into consideration. This presentation highlights the importance of adequate preparation, constant vigilance, and a firm grasp of clinical knowledge to achieve optimum perioperative outcome. Thank you and good day to all.
Thank you, Dr. Pervera. Our fourth interesting case is entitled Anesthetic Challenges in Open Repair of Extracranial Common Carotid Artery Aneurysm, a case report. Let us welcome Dr. Jacqueline D. Pardo.
Hi. Good day. I will present a case report on anesthetic challenges in open repair of an extracranial common carotid artery aneurysm. Our case is a 56-year-old right-handed female weighing 59 kilograms with a 3-year history of gradually enlarging neck mass. Significant comorbid conditions include bronchial asthma and hypertension. She completed treatment for pulmonary tuberculosis and tuberculous meningitis 3 years ago, but had residual decreased visual acuity of 20/400 on both eyes. Her blood pressure in the wards ranged between 100 to 120/60 to 80. Pertinent PE showed a 5/5 cm non-pulsatile right anterior neck mass with no carotid bruits. Neuro exam also showed no sensory motor deficits and no cranial nerve deficits, save for the decreased visual acuity. Her neck ultrasound showed multinodular non-toxic goiter and focal dilatation of the right common carotid artery with thrombus formation. CT neck angiogram showed a 4.5 cm sacculofusiform aneurysm involving the right common carotid artery. Carotid ultrasound revealed moderate to severe right ICA stenosis and mild left ICA stenosis. Surgical plan was partial sternotomy, right common carotid endoaneurysmorraphy. Anesthetic assessment is ASA-3 for a high-risk patient undergoing a high-risk procedure. Our plan was to do general endotracheal anesthesia with hemodynamic and neuromonitoring using a cerebral oximeter and intraoperative EEG with neurology. Preoperative preparation included blood products and possible use of cell salvage. She was premedicated with the following agents, and prior to induction, standard ASA monitors were attached. An arterial line was inserted under local anesthesia. Baseline cerebral oximetry values were normal, with the left measuring 60 to 63% and the right 65 to 68%. Baseline EEG tracing showed background activity consisting of medium voltage 9 to 10 Hz alpha activity. General anesthesia was induced with midazolam, remifentanil TCI at 4 nanogram per ml, propofol TCI at 4 microgram per ml, and rocuronium 1 milligram per kilogram. Anesthesia was maintained with less than 1 max sevoflurane, remifentanil TCI, propofol TCI, and rocuronium. Norepinephrine infusion was started to maintain blood pressure of 110 to 130. However, a decrease in the frequency of the EEG background activity to 7 to 8 Hz was observed, coinciding with a decrease in the blood pressure to 90 to 100. Norepinephrine was titrated up to achieve RBP targets. After the carotid branches were exposed, heparin was administered at 100 units per kilogram. A repeat baseline EEG was taken 5 minutes prior to clamping, showing medium voltage 8 to 9 Hz alpha waves admixed with occasional 4 to 5 Hz theta waves. A 4 by 5 by 4 cm fusiform aneurysm arising 3 cm from the proximal RCCA was isolated and repaired using an interposition Dacron graft. No major change in EEG waveforms was seen during the 45-minute clamp time. There was a return to the pre-induction background activity on the EEG once the BP stabilized at 110 to 130. Cerebral oximetry values were also maintained within 20% from baseline throughout the procedure. 1 unit packed RBC was transfused intraoperatively, and point-of-care test showed normal acid base and a hematocrit of 33. Neuromuscular blockade was reversed with Sugamidex, and patient was extubated with remifentanil TCI at 1 nanogram per ml. She was able to follow commands and had no apparent signs of neurologic deficit prior to transfer to the PACU. She was monitored in the PACU telemetry unit for 72 hours. Anticoagulation was resumed, and there were no neurologic deficits noted during the post-operative course. However, she had low blood pressure around 90 millimeter mercury and a relative increase in heart rate on the second post-operative day. Investigation showed anemia of 67, which improved after transfusing 1 unit packed RBC. She was discharged on the 7th post-operative day, and on follow-up, she had no complaints pointing to neurologic deficits. Extracranial carotid artery aneurysms are rare, with an incidence of 0.4 to 4% of all aneurysms and less than 1% among peripheral artery aneurysms. Due to its locations, ECCAs have an increased risk of neurologic complications, including thromboembolic stroke, nerve compression, as well as rupture. Treatment options include medical management, open surgical repair, and endovascular treatment. Due to its rarity, repair of carotid aneurysms comprises less than 5% of carotid surgeries. Open repair is the preferred management for symptomatic and growing aneurysms. There are scarce recommendations for the ideal anesthetic management for ECCA repairs. General anesthesia is preferable in our case because partial sternotomy was done to access the aneurysm. Moreover, its advantages include technical ease, presence of a secured airway, and optimal surgical conditions. Nonetheless, it is not devoid of challenges in neurological assessment and maintenance of hemodynamic stability. Anesthetic goals include maintenance of adequate cerebral perfusion and oxygenation, maintenance of cardiovascular stability and avoidance of myocardial ischemia, monitoring of cerebral blood flow adequacy during cross-clamping, avoidance of hemodynamic lability perioperatively, and provision of rapid smooth emergence to be able to assess neurologic status post-operatively. Electroencephalogram is considered the gold standard for neuromonitoring in carotid artery surgery under general anesthesia. However, reliable interpretation of the EEG is dependent on experienced neurophysiologists and adequate availability of equipment. Cerebral oximetry uses near-infrared spectroscopy to monitor regional oxygen saturation. A cutoff of 25% decrease or 20% decrease for more than 4 minutes in cerebral oximetry values during carotid artery clamping may be a reliable indicator of decreased perfusion. However, it only monitors oxygen saturation of the frontal lobes and has shown low sensitivity and specificity in predicting the need of intraoperative shunting. Healthy adults will show beta waves in the EEG during wakefulness, while alpha activity in the occipital areas is seen in awake patients with eyes closed. Theta activity is usually seen during drowsiness and light sleep, while delta waves characterize deep sleep activity. When there is decreased perfusion during carotid clamping, significant ipsilateral slowing or attenuation of the EEG waveform or even loss of signals may be seen. The EEG is affected by various factors, as was seen when the hypotensive episode in our patient coincided with slowing of the EEG waves. Volatile agents should also be kept to less than 1 Mach to avoid interfering with the EEG. Hence, a balanced anesthetic technique was used. Remifentanil has the advantage of being rapidly titratable. Upon extubation, severe hemodynamic changes and coughing may be avoided with continuation of remifentanil infusion. Due to its rapid clearance upon discontinuation, quick emergence allows early neurological assessment. Another complication for carotid aneurysm surgery is the potential for bleeding due to preoperative antiplatelet use, systemic heparinization, and potential of rupture of the aneurysm. Blood products and cell salvage were prepared beforehand in our case, and hematocrit values were also used to guide for the need to transfuse packed RBC. To conclude, the choice of anesthetic technique for open common carotid aneurysm repair will still depend on the expertise and preference of the surgeon and anesthesiologist and preference of the patient. In this case, general anesthesia was done due to the requirements of a sternotomy, as well as preference of the patient and healthcare team. Monitoring of adequate cerebral perfusion is important to determine need for additional surgical or anesthetic intervention perioperatively. Enhanced clinical outcomes and avoidance of complications will depend on surgical technique, fluid and blood pressure management, and adequate anticoagulation. Postoperative management is crucial to assure good results. Blood pressure should be balanced to allow adequate perfusion through the graft while avoiding risk of rupture. These are my references. Thank you.
Thank you, Dr. Pardo. Okay, the last interesting case for the first set is entitled Anesthetic Management of Bardet-Biedl Syndrome, a case report. Please welcome Dr. Matthew Marion L. Kang.
Good afternoon, doctors. What is Bardet-Biedl syndrome? What are its anesthetic challenges, and how can these be managed? Presenting a case of MC, a 30-year-old female Filipino Roman Catholic who has type 2 diabetes mellitus, retinitis pigmentosa, thoracic myelopathy, and intellectual disability. With unremarkable personal and social history. Her family history includes diabetes and hypertension with no known history of other related syndromes. 1 year prior to admission, patient had problems with walking and balance. 1 month prior to admission, symptoms progressed, thus she was admitted for workup. MRI revealed thoracic myelopathy secondary to ossification of the ligamentum flavum, and family was appraised for posterior decompression and instrumentation of thoracic spine. Patient was then readmitted for planned procedure. Upon examination, the patient was awake and cooperative. Height was 152 cm, weight 70 kilograms, with a BMI of 30. She had wide-spaced eyes, exotropy in the left eye with horizontal nystagmus, and she also had a short neck with truncal obesity, limiting neck extension. For the airway assessment, Malpati score was 4, mouth opening greater than 2 finger breadths, and a thyromental distance less than 3 finger breadths. For the neurologic examination, the patient had gait problems with motor strength of 4 out of 5 of both lower extremities, decreased vibratory sense, and decreased pain sensation in the left lower extremity 80% compared to the right 100%, and loss of position sense in the left lower extremity and positive Babinski reflex on the right foot. MRI showed segmental thickening and ossification of the posterior longitudinal ligament from C3 to T12 with ventral dural sac indentation, moderate central canal stenosis, bilateral neural foramen stenosis, and spinal cord edema. She was placed on NPO and preoperative medications were given. Anesthetic technique planned was GAETT-TIVA with video laryngoscopy and fiber optic bronchoscope on standby. On the day of the surgery, pre-induction vital signs were within normal limits. Awake intubation was performed, and we had 3 failed intubation attempts using the video laryngoscope due to the patient's large tongue size and anteriorly placed glottic opening. Visualization via video laryngoscopy showed a Cormack-Lehane score of 2B. We then switched techniques and used the fiber optic bronchoscope. After difficulty in inserting an armored ET tube, successful intubation was achieved using a standard ET tube. Visualization via the airway via FOB revealed a bifid epiglottis, shown in the first photo, which unfortunately could not be appreciated due to the rapid sequence of events, and 3 main bronchi in the second photo. IV induction with propofol 50 milligrams was given, followed by rocuronium 50 milligrams for paralysis. Patient was positioned prone and appropriate padding was applied. Anesthesia was maintained using propofol via manually controlled infusion and fentanyl boluses. Somatosensory and motor evoked potentials were monitored. Vital signs were stable throughout the procedure. Patient had episodes of hypotension during emergence, which was managed with crystalloid fluid boluses. In the post-anesthesia care unit, hemodynamic instability was corrected with norepinephrine infusion. She was later transferred to the ICU for monitoring, and 1 unit PRBC was transfused due to hemoglobin drop of 10.2 and hematocrit of 28.7 from hemoglobin of 15.9 and hematocrit of 45.1. Post-operatively, the patient had minimal tolerable pain with no subjective complaints. 1 week after the surgery, the patient was discharged and scheduled for follow-up consultation 1 week after. Fellow doctors, Bardet-Biedl syndrome is a rare genetic cellulopathic disorder. Incidence rates in North America and Europe are 1:140,000 to 1:160,000, and I have come across 2 journals which describes 3 other patients with the same features of Bardet-Biedl syndrome in the Philippines. To clinically diagnose Bardet-Biedl syndrome, 4 primary features or 3 primary plus 2 secondary features are required to be present. My patient presented with 4 out of the 6 primary features. She also presented with all the secondary features. Anesthetic considerations in BBS include craniofacial features that present with bifid epiglottis that may be flaccid and obstruct the glottic opening, thus limiting airway entry, and obesity that may present with increased airway and neck adiposity. All these can make intubation challenging. Intellectual disability is a challenge when explaining the contemplated procedure to a patient with BBS because a cooperative patient is essential in performing an awake intubation. Fortunately, my patient was able to comprehend the instructions given to her and cooperate during the procedure. Orthopedic manifestations relate to airway structure abnormalities such as bifid epiglottis, especially if the patient has polydactyly. Patient also present with autonomic dysfunction that cause hemodynamic instability. And there's high incidence of cardiac abnormalities in patients with Bardet-Biedl syndrome. And awake sedation and fiber optic intubation are the mainstay management in patients with Bardet-Biedl syndrome. According to the Difficult Airway Society, these are the important elements of an awake tracheal intubation. First is to ensure adequate oxygenation. Next is to anesthetize 3 key areas, namely the nasal airways, the pharynx, and the base of the tongue. Mild sedation may be given to ensure patient comfort. And lastly, the patient must be positioned properly to facilitate smoother intubation. In conclusion, Bardet-Biedl syndrome is a rare genetic celipathic disorder which presents with structural differences that prompt careful preoperative planning and utilizing advanced techniques such as awake fiber optic intubation for safer airway and anesthetic management. These are my references, and thank you.
Thank you, Dr. Kang. So those were the first 5 cases for this contest. No? So we will now proceed with the question and answer portion. Now each judge will ask 1 question for every presenter. So each presenter will be asked 3 questions. No? So may I call Dr. May I call Dr. Michael Ryan Manera first for your case report on the airway management of a pediatric patient with ankyloblepharon ectodermal dysplasia clefting or AEC syndrome using 2-stage Styles technique. So we will start with Dr. Ruben Suceso.
Good afternoon.
Good afternoon po, ma'am.
Thank you, Dr. Manera, for your presentation. My question is, did you use a generic form for your informed consent? Because how is obtaining an informed consent from an adult different from that of a pediatric patient?
Sorry, ma'am, can you please repeat the question po?
Did you use a generic form for your informed consent? Because how is obtaining an informed consent from an adult different from obtaining it from a pediatric patient?
For this case po, we presented for this case po, we extracted the consent from the mother of the patient using the general consent form po. And upon getting of the consent, we demonstrated the benefits and the risk that would happen in the patient, and the mother understood and was amenable to whatever can happen to the patient po, to the baby po, ma'am.
The comment kasi is the consent was worded that it's as if the interventions were being done on the one who signed it and not on a child. So you should have reworded the consent form.
Thank you po, ma'am.
Thank you, Dr. Ruben Suceso. May we call on Dr. Duldulao?
Hello, good afternoon.
Good afternoon po, ma'am.
Okay, doctor. My question is, during the time when you were doing your 2-stage Styles technique, how was the oxygenation of the patient managed during that time? And what was the oxygen saturation then?
Yes, for the two-stage TALS technique, one of the main benefits of this technique is the ability to ventilate the patient using a high humidity pediatric GA mask. No problems were encountered during the oxygenation during the intubation. A patient did not desaturate, and we were able to intubate the patient well naman po.
Okay, thank you.
Thank you po.
Thank you, Dr. Duldulao. May we now call on Dr. Mariano for her question.
Okay, good afternoon, Dr. Manera.
Good afternoon
and
po, ma'am.
Congratulations for surviving the case.
Thank you
Okay.
po.
So my question is that you mentioned that there was no mouth opening. That's why you did this nasotracheal intubation.
Yes
So
po.
para siyang antegrade intubation, di ba?
Mhm.
So my question here is, please describe the procedure when shifting from nasotracheal intubation to endotracheal intubation. So I was wondering kung yung endotracheal intubation is oral also?
Yes, ma'am. Oral po.
So how about the problem of no mouth opening? So will you please enlighten us on that? Thank you.
Yes po. The conversion from the nasotracheal to endotracheal intubation was done after the removal of the coronoid process in the mandible. So there was already mouth opening from 0 centimeters to 3.5 centimeters po. So during the conversion, we did it under video laryngoscopy, and upon removing of the nasotracheal tube, the endotracheal tube was there. We will insert it once the nasotracheal tube has been removed. So there will be less time or less lag time in the conversion from the nasotracheal to endotracheal tube po. So there was already mouth opening po at that time.
You should include that in your paper because it's not clear for the readers on what happened.
Yes po, ma'am.
Thank you.
Thank you po, ma'am.
All right, thank you, Dr. Manera. May we now call on Dr. Baluga for her paper, Retrograde Intubation in Patient with Oral Squamous Cell Carcinoma, a case report. Are you already here, Doctora?
Yes po, ma'am. Good afternoon.
Okay, thank you. May I ask Dr. Duldulao first to give the first question?
Okay, good afternoon, doctor.
Good afternoon po, ma'am.
Okay, congratulations for presenting your paper. My question is, you mentioned in your manuscript patient was extubated 40 hours post-operatively. So what were your considerations then? Why not on the 24th hour or on the 12th hour or on the 72nd hour?
Thank you po, Doc. Doc, it was 40 hours. We extubated the patient 40 hours post-operatively because we, at the anesthesia, at the special care area of the ENT, we observe the patient if he can tolerate room air. Then we observe the patient if he can tolerate room air and he can tolerate extubation. So after 48 hours, the surgeons informed us that the patient can now be safely extubated. So I was with two senior anesthesiologists, and with necessary equipments like SGA, nasal and oral airways, and bougies in case there will be a problem. So, but we were confident that the patient can be extubated because the defect has already been repaired, and bag mask ventilation can be done, and SGA insertion can be done also po. Thank you po.
Okay, thank you, Dr. Duldulao and Dr. Baluga. May I now call on our chair, Dr. Mariano, for the second question.
Okay, hello, Dr. Gira, and also my congratulations for having done this case successfully. So retrograde intubation has already existed during the time of our residency ni Dr. Cano. But I will not tell you the year, okay? So I believe that retrograde intubation is something that the residents should be able to do. Pero currently, we have this advanced airway equipment which they say that it removes the word difficult from difficult airway management. So my question is, what is or are the indications for conventional intubation or the use of advanced airway equipment in this case?
So, the contraindications would be, first po, is patient refusal po, Doc. And the anatomical defect of the patient also, Doc.
Okay, so kung nag-refuse yung patient, that is really a contraindication. But parang hindi ko nabasa sa paper mo yon. So if that is one of the reasons, pakilagay na lang sa paper. Okay,
Yes,
thank you.
Thank you.
Thank you, Dr. Mariano. May I now call on Dr. Buensuceso?
Good afternoon, Doctora. Thank you for your presentation. One comment and one question also. In presenting your patient information, it's important that the information should be identified. In your manuscript, you even said yung civil status, religion, the exact birthday, place of residence. So my question is similar to the first case, and of course I won't be asking this anymore for the subsequent presenters. This is just to stress the importance of the informed consent. Did you obtain one from your patient?
Yes, po, Doc. We thoroughly explained the procedure, Doc.
The informed consent for the procedure is different from the consent for using him, for presenting him as a case report. So did you do the latter?
Yes po, Doc. We obtained an informed consent.
So it would be good if you included that in your manuscript.
Thank you po, Doc.
Okay, thank you, Dr. Buensuceso. May I now call on Dr. Jordon Carl Pervera for his case, Complexities in its Rarity, a case report of a fast-growing giant mesenteric mass in a pediatric patient, complicated with renal agenesis and congenital heart disease. Dr. Mariano, can you give the first question?
Okay, again, I'm glad you survived the case, Dr. Pervera.
Thank you, Doctor.
Congratulations for that. The case is really complicated with the patient having plenty of comorbidities. So, since this is a difficult case, I will also ask you a difficult question. De joke lang yun. Okay. So, di ba yung blood loss is around 500 cc?
Yes, Doctora.
So will you consider the total estimated blood loss of 500 cc as a massive blood loss for the child's age and weight?
Yes, Doctora.
Okay. And please describe lang in 1 minute after you answer the question, the blood management in children for the sake of your co-residents.
Okay.
Thank you.
For our patient did have massive blood loss. The estimated blood volume for this patient was 910 cc, and the blood loss was 500 cc. Although we were very concerned about overloading the patient, so we liberalized, we were goal-directed in our fluid management and also our blood transfusion. According to literature, blood transfusion in children has negative effects, and so you have to consider them. But in this case, we replaced volume for volume in terms of blood so that we prevent overloading the patient. Since the patient has left to right shunt, so in patients with left to right shunt, you don't want to overload the patient, the patient's right side or the pulmonary vasculature, since you can cause congestive heart failure. And also we were concerned about perfusion in this case, but we replaced the volume, the blood volume per volume. Thank you, Dr.
Okay.
Thank you, Dr. Mariano. May I call on Dr. Buensuceso?
I had a similar question about blood loss because you did not expound on the allowable blood loss in your manuscript. So my question now is that you said that the patient was discharged on the 97th hospital day. Is this equivalent to what day post-op? And has there been a follow-up since the discharge of the patient?
The patient, the 97th hospital day was in totality. The post-operatively, it's about 80th day. Unfortunately, the patient's from Quezon. So after the 97th day, we couldn't reach the patient anymore because we were trying to reach him. But during the days from post-op, from days to post-op to the 97th hospital day, we're closely monitoring the patient. And the patient was discharged on the 97th hospital day because there were episodes of hospital-acquired pneumonia during the medical management about a week or 2 weeks after the procedure. And also the patient has to be nutritionally built up for safe discharge. So that's why the patient was discharged on the 97th hospital day.
Thank you.
Thank you, Dr. Buensuceso. May I call on Dr. Adul-Dilao?
Oh, okay. Congratulations, doctor, for presenting your case. My question is, in your manuscript, you have mentioned primary intraoperative anesthetic considerations include management of dehydration, hypovolemia, acidosis, and hypothermia. Did you monitor the if ever your patient had acidosis intraoperatively, and how?
We had our capnograph intact, but since we are facing with massive blood loss, so we were expecting acidosis in this patient. So we managed the patient goal directively because for one, we don't again we did not want any fluid overload. But in terms of acidosis, we were post-operatively we ordered ABGs. We monitored the physical exam, capillary refill. We do in our institution we do not have sophisticated monitors, so we relied on physical exam, ABGs, CBC, more of the ancillaries, and also the physical exam and physical exam for the patient.
Okay. All right. Thank you, Dr. Pervera. May we call on our next presenter, Dr. Jacqueline Pardo, for her paper entitled Anesthetic Challenges in Open Repair of Extracranial Common Carotid Artery Aneurysm, a Case Report. May we have the first question from Dr. Buensuceso?
There's no mention of your baseline laboratory values. And then you had an intra-op blood loss of more than a liter for which you transfused only 1 unit of packed RBC, while post-op hemoglobin was already 67. So why was this so? And another side question is, why is there no how did you manage the post-op pain of the patient?
For the blood loss, ma'am, our baseline hematocrit was 37, and then we got a baseline point of care test before commencement of the surgery, which was also around 36 to 37. We only transfused 1 unit packed RBC because after transfusion and before emerging the patient, our point of care test showed a hematocrit of 33. Our initial post-operative hematocrit was around, I think, 29 to 30% with no high potential, so we opted not to transfuse another unit of packed RBC. However, on the second post-operative day, we noted borderline low blood pressure of SBP of 90, and on checking, we had a hemoglobin of 67, so we decided to transfuse another unit post-op. For the pain management, ma'am, we gave the patient paracetamol 600 milligrams, I think Q6, and then morphine 2 milligrams every 4 hours until the second post-operative day, and then we shifted that to Dolcet, paracetamol and tramadol.
Okay, Dr. Bensuceso. May I now call on Dr. Duldulao for her question?
No further question. Thank you.
I think it's Dr. Pardo who will say thank you, not me.
Thank you.
So may I now call on the chairman of the board, Dr. Mariano, please.
Okay, congratulations, Dr. Pardo, for your report, and kasi walang question si Dr. Duldulao for you. So my question is similar to Dr. Fuensuceso, and you already mentioned that you gave morphine every 6 hours?
Every 4 hours, ma'am, for the first 24 to 48 hours.
Okay, and then you shift the patient to the fixed dose tramadol and paracetamol. But you did not mention that in your paper.
Yes.
So, paki-mention. So, at least I can ask my second question. So, di ba the patient had symptoms like tenderness in the here, numb sensation in the right mandibular and other areas, and she has also occasional pain, coughing and sneezing even after 1 month after the procedure. So what are the possible reasons for the symptoms the patients are having?
I inquired with thoracic and cardiovascular surgeon, ma'am, who did the procedure. Since the patient has not yet followed up with them after, I think 2 weeks pa lang siya she only followed up 2 weeks after, and then she was not able to describe the numb sensation to the surgeon. I asked the surgeon about it. His opinion is that there could be a cutaneous nerve injury in that area. But since this is a minor discomfort, the patient failed to report that to the surgeon.
Okay, that's a very good communication with the surgeon. So you also follow up your patient with the surgeon because sometimes kung wala namang severe pain, hindi sila nagpa-follow up sa atin. Okay, thank you, Dr.
Thank you po.
Okay, thank you, Dr. Pardo. And last but not the least, may I call on Dr. Matthew Marion Kang for his paper, Anesthetic Management of Bardet-Biedl Syndrome, a case report. May we start with Dr. Duldulao?
Okay, good afternoon, doctor. My question is, you mentioned about bifid epiglottis and the 3 main bronchi you have noticed during the procedure. So how did these 2 concerns affected your management?
For the bifid epiglottis, doc, since it might be flaccid, it might, as I mentioned earlier, it might cover the glottic opening, therefore making the airway visualization even more difficult. So thankfully, using the fiber optic bronchoscope, it was more manageable. But for the 3 main bronchi, we failed to visualize if the 3rd one was a blind pouch or if it had any function, but so far during the procedure, it did not pose any difficulty for the anesthetic management. Thank you.
Okay, thank you, Dr. Duldulao. May I call on Dr. Mariano for the second question?
Okay, Hello, Dr. Kang, and congratulations also for presenting the case. So my question is that before administering anesthesia, what devices or other preparations did you do in anticipation of the difficult airway?
So we prepared the patient first with atropine. We gave her 0.5 milligrams atropine, lidocaine spray, and we also had the fiber optic bronchoscope on standby with all of it set up already in the OR. Yeah. That's it.
Okay, thank you.
Thank you.
Okay, thank you, Dr. Mariano. May I have your question, Dr. Buensuceso?
Good afternoon, doctor. Thank you for your presentation. You mentioned that the syndrome is a genetic disorder on ciliopathy, and there are very many features, manifestations of this. So which among these have correlation with the ciliopathy? And a side comment is that how did you do your review of it? You only had 3 references in your written manuscript, while in your presentation, I think you showed 4.
So for the first question, Doc, can you repeat, Doc, the first question? I focus more on the
Your
second.
definition of Bardet-Biedl syndrome is that it is a rare genetic ciliopathy disorder, while the manifestations are multisystemic. So are all of these manifestations attributable to ciliopathy, like obesity, polydactyly?
Yes, Doc. My patient presented with the polydactyly. However, during her childhood, her parents opted to take out the extra toes, and then for in the papers that I read, the most we can consider for making a management with Bardet-Biedl syndrome difficult is if they have renal and cardiovascular problems, because that's the most reason for their morbidity. But so far for my patient, we did pre-op evaluation, so we did 2D echo, we had an MRI, so the patient was stable. And then as for the second question, Doc, I added the fourth reference because of I just added the airway from the Book of Barash.
Okay. Thank you, Dr. Buensuceso. Thank you to the first 5 presenters of the interesting case contest. Let us now proceed to the next set of interesting cases. For the case, eventration of the diaphragm, post-arterial switch operation, a case report, may I call on Dr. Jamie Rose Mojica.
Good afternoon, everyone. I am Jamie Rose Mojica, and I'm going to present a case about eventration of the diaphragm post-arterial switch operation. TRT is a duty-old male from Sampaloc, Manila, who was admitted due to cyanosis upon birth secondary to a fetal cardiac anomaly. He was born full-term to a 38-year-old G2P2 mother via primary cesarean section secondary to fetal cardiac anomaly. TRT weighed 3.2 kilograms, had a good APGAR score, and had normal anthropometrics for age. At 27 weeks AOG after pregnancy was confirmed, a congenital anomaly scan was done, and transposition of the great arteries was suggested. Fetal echocardiogram the following week confirmed this, and at 38 weeks and 2 days, TRT's mother underwent primary cesarean section. Both his parents had hypertension and his father had diabetes. Social history is unremarkable. Patient had no fever or chills, but was noted to be weak and cyanotic. No other physical deformities were noted. Patient was seen awake with good cryon activity and carried by his mother. Oxygen saturation remained at 82% at room air, and patient was noted to have circumoral and peripheral cyanosis. 2D echo showed a patent ductus arteriosus and a patent foramen ovale, both measuring about 3 millimeters. Good biventricular contractility was noted, as well as transposition of the great arteries with an intact ventricular septum. The patent ductus arteriosus is an abnormal communication between the aorta and the pulmonary artery. To maintain this, a prostaglandin infusion was started. At the same time, balloon arterial septostomy through the foramen ovale was attempted with the intent of building up the atrial septal defect and improve oxygenation prior to doing the switch operation. However, this was unsuccessful and failed to increase systemic oxygenation. The patient was then scheduled for an arterial switch operation. Prior to transfer to the operating room, the patient had an episode of bradycardia, which responded with an epinephrine bolus. The patient was eventually intubated and an epinephrine infusion was started. In the operating room, atropine, midazolam, fentanyl, and rocuronium were used as intravascular induction agents. Anesthesia was maintained with midazolam, fentanyl, and rocuronium boluses. Hemodynamics were maintained with infusions of milrinone and epinephrine. Despite adequate perfusion, contractility, and the absence of bleeding, the patient had bradycardic episodes when chest closure was attempted. After 2 failed attempts, chest closure was eventually delayed. The patient was then transferred to the cardiac ICU, intubated, sedated, and paralyzed with dexmedetomidine, fentanyl, and rocuronium for pulmonary compliance, aiming to maintain oxygen saturation above 95% to effectively wean from mechanical ventilation while building up nutritional status. IV fluids and furosemide infusion were restricted to 65% of full maintenance with increasing frequency in the first 72 hours postoperatively in anticipation of ventricular dysfunction and low cardiac output states. Serial laboratory examinations were done to check for electrolyte imbalances, anemia, and adequate perfusion, as well as an echocardiogram and a babygram. The patient remained hemodynamically stable with decreasing requirement of inotropes. By the 7th postoperative day, chest closure was successfully done. With the completion of dexamethasone doses, extubation was attempted on the 15th postoperative day, which was unsuccessful due to the presence of deep intercostal and subcostal retractions. Left phrenic nerve paralysis was suspected and the patient was reintubated. The babygram confirmed an elevated left hemidiaphragm, further confirmed by a diaphragmatic ultrasound. The patient underwent plication of the left hemidiaphragm and tracheostomy under balanced general anesthesia. The perioperative period was unremarkable. Oxygen support was gradually weaned and weaning from tracheostomy was done. Balanced general anesthesia consists of using different drugs to achieve at least approximately each of the separate characteristics of the anesthetic state. This uses less of each drug than if the drug were administered alone, thereby increasing the likelihood of its desired effects and reducing the likelihood of its side effects. After 60 days, the patient was discharged stable and improved. These figures showed babygrams taken post-diaphragmatic plication to the left and after tracheostomy tube removal to the right. This X-ray shows our patient 8 months post-diaphragmatic plication. The diaphragm is a thin muscle forming the roof of the abdominal cavity, the main muscle humans use for inspiration. An elevated hemidiaphragm ensues when one or both sides of this muscle is weakened due to muscular disease and phrenic nerve injury, leading to innervation loss. Eventration of the diaphragm is relatively rare and life-threatening, mostly seen in young children and infants after recent cardiothoracic surgery. In this condition, the diaphragm stays constantly raised, preserving its attachment to the costal margin. Varying reports on the incidence of this disorder range from 0.46 to 4.6%, with all age groups mostly manifesting this condition in increasing frequency after open heart surgery. The phrenic nerve provides the primary motor supply to the diaphragm to allow human respiration. Both left and right phrenic nerves supply motor and sensory fibers. Phrenic nerve injury requires a high index of suspicion due to its nonspecific signs and symptoms. On physical examination, findings may include decreased breath sounds on the affected side, dullness to percussion in the affected side of the chest, and inward movement of the epigastrium during inspiration. Diaphragmatic eventration starts with diaphragm dysfunction, which allows the ineffective work of breathing and decreased diaphragm movement of the affected side during inspiration. When present, adequate gas exchange is impaired in infants due to their reliance on diaphragmatic contraction. The affected side is also pulled further upwards on inspiration due to negative intrapleural pressure. Coupled with a reduced vital capacity when lying down, this promotes atelectasis, obstruction from retained excretions, and alveolar collapse. Diagnosis of diaphragmatic eventration in infants is difficult, as spontaneous ventilation is needed to identify paradoxical movement of the affected diaphragm. Early diagnosis traditionally relies on a high index of clinical suspicion, supported by radiographic evidence of elevation of the injured hemidiaphragm, then confirmed by fluoroscopy. Accurate diagnosis of diaphragmatic eventration and phrenic nerve paralysis involves direct percutaneous stimulation of the phrenic nerve, providing access to patients on full ventilation. Although highly accurate, it is painful to infants, therefore ultrasound guidance is used because it's non-invasive and repeatable. A widely accepted treatment plan for patients with eventration of the diaphragm is plication. In symptomatic cases, alleviation and eventual resolution of respiratory symptoms is valuable. All of the much-awaited benefits of this procedure are long-term and do not interfere with a return of diaphragmatic function that may occur spontaneously within 18 months to 3 years. Nerve grafting is a major dynamic treatment used to repair brachial plexus injuries and extremity paralysis or isolated cases of complete acute injuries to the phrenic nerve. This includes nerve decompression and interposition grafting for segmental phrenic nerve injury and nerve transfer for a proximal phrenic nerve or cervical root lesion. Phrenic nerve operations to restore diaphragmatic function broaden therapeutic options. When no spontaneous recovery is seen, restoring neurologic function in patients with diaphragmatic eventration is the ideal first-line treatment. Diaphragm pacing provides an alternative method of ventilatory support with application of electrical stimulation to the phrenic nerves. However, only a specific category of patients with chronic respiratory failure will benefit from this. The benefits of diaphragmatic plication are noteworthy. Besides expedited weaning from mechanical ventilation when successful, return of spontaneous diaphragmatic function in both children and adults may also be observed. Anesthesiologists need to be vigilant to be able to recognize dangers or complications early. Post-operative monitoring is also essential to be able to watch out for coexisting conditions and difficulties so that we may be able to provide better perioperative care to our patients. Phrenic nerve palsy can be highly considered in post-cardiothoracic surgery patients that are difficult to wean from the mechanical ventilator. Here are my references. Thank you.
Thank you, Dr. Mojica. May I now call the presenter for the next case, entitled Anesthetic Challenges of Anterior Neck Penetrating Injury, a Case Report. Dr. Isabella Francesca B.C.
Penetrating neck injuries can be a life-threatening event, and they usually require emergency surgical treatment. Due to the anatomical complexity of the neck region, managing these patients is very difficult and dangerous for both the surgeon and anesthesiologist. Securing the airway is of utmost importance during induction and maintenance of general anesthesia. This is a challenge, most especially when the surgery would involve the airway itself. Here are my objectives. This is a case of AK, a 7-year-old male, 25 kilograms, Filipino, Roman Catholic from Calamba City, who was admitted for the first time in our institution due to a penetrating anterior neck wound. The patient's condition started a few hours prior to admission. While playing with his friend, he accidentally incurred a penetrating neck wound by a metal rod. On physical examination, the patient was awake, active, comfortable, not in cardiorespiratory distress, with stable vital signs. The foreign body presented as a metal rod penetrating the anterior neck, midline zone 2, puncturing the cricoid cartilage approximately 1.5 centimeters. Patient was then scheduled for an emergency operation for neck expiration, foreign body removal, and tracheostomy procedure. The patient's status was stratified using the American Society of Anesthesiologists classification, as a class 1 was assigned to the patient, classifying him as a healthy individual. The airway of the patient was evaluated and classified as Malampati 1. The patient was received at the operating room station via wheelchair, fully awake, febrile, with cardiac rate of 115 beats per minute and respiratory rate of 22 cycles per minute. Pre-medication of atropine 0.3 milligrams and midazolam 2 milligrams were given intravenously. Induction of anesthesia was carried out with ketamine 25 milligrams and propofol 30 milligrams intravenously. IV sedation lasted for 65 minutes until oxygen desaturation occurred. Hence, intubation was attempted using direct laryngoscopy when the patient had desaturation episodes of 88 to 50%, accompanied with bradycardia with cardiac rate ranging from 40 to 50 beats per minute. Intubation failed due to the metal rod partially obstructing the trachea. A second attempt on intubation was done, but now the anesthesiologist decided to hold the endotracheal tube near the obstruction to be able to deliver oxygen while the surgical team worked on removing the foreign body from the patient's neck. Manual bagging was done in between attempts to maintain oxygenation, but desaturation was still persistent, accompanied with bradycardia. 2 doses of atropine, 0.3 milligrams, within 3-minute interval was given. Once the foreign body was removed, the patient was successfully intubated under direct visualization using a Macintosh Blade 3 with ET tube size 5. The endotracheal tube was secured at level 15 with equal breath sounds noted on both lung fields. Neck exploration, repair of cricoid cartilage, and tracheostomy was then carried out. The surgery lasted for approximately 4 hours since the time of induction. Securing the airway is said to be an all or none situation in which the life of an individual literally lays on the hands of the person attempting to provide a continuity of oxygenation. In the operating room setting, it is the anesthesiologist who is usually given the task in managing the airway. Thus, anesthesiologists are trained to secure a patient's airway even amidst the most difficult of anatomical distortions. Securing the airway in the pediatric patient is relatively more difficult due to the difference in the anatomic structures. This includes a large head and tongue, a mobile epiglottis, the anterior position of the larynx. These factors alone make airway management of a pediatric patient a real challenge for the anesthesiologist. The ASA algorithm for management of difficult airways is a useful starting point for the anesthesiologist. However, as the algorithm suggests, reawakening a patient after difficulty in securing the airway is usually not an option. Tracheal intubation must be achieved using conventional or surgical means. Early detection of possible difficulties that may arise during intubation is indeed one of the most significant tasks of the anesthesiologist. Endotracheal intubation continues to be the gold standard for the maintenance of airway patency and gas flow. In our case, a direct laryngoscopy was employed. However, the anesthesiologists were aware that intubation would not be easily accomplished due to the partial obstruction in the trachea. Hence, this attempt was done by 2 operators. The first operator secured the position of the endotracheal tube with the use of a simple laryngoscope with Macintosh Blade 3, while the second operator manually bags the patient to deliver oxygen and anesthetic gas while the surgical team removed the foreign body penetrating the patient's neck. Ketamine was the intravenous agent used to induct the patient. This was chosen because of its unique property of being able to preserve airway patency and provide bronchodilation. Aside from ketamine, sevoflurane was also utilized once the foreign body was removed and the patient was successfully intubated. The principle behind safe induction of anesthesia in the difficult airway is the maintenance of spontaneous ventilation. Procedures involving extensive dissection around the neck and upper thorax warrants that the patient remains intubated or has a tracheostomy placed. A tremendous amount of upper airway edema is expected to ensue, which would make early extubation life-threatening. One should always be on the alert for airway obstruction and ready to intercede with reintubation or tracheostomy if prompt deterioration occurs. As in our case, a tracheostomy procedure was done to prevent possible post-operative obstruction and complications. A thorough preoperative evaluation is of great value in the preparation for the induction and maintenance of anesthesia. If possible, specialized devices and innovative modalities for intubation should be secured prior to induction of an expected difficult airway. A protocol for difficult airway management should be tailored according to the readily available resources of each institution, and such guidelines should be routinely rehearsed in the event that another case of difficult airway should be encountered in an emergency scenario. With adequate preoperative preparation, careful intraoperative monitoring, and immediately addressing the possible intraoperative complications, as well as appropriate postoperative management, a patient who will undergo neck expiration and removal of a foreign body is headed to a successful surgical and anesthetic outcome. Thank you and good day.
Thank you, Dr. C. May I now call the presenter for the next interesting case, pain demonium, a case report on the use of ultrasound-guided ganglion impar block for the management of chronic rectoanal pain. Please welcome Dr. Mary Uy.
Pain is the most debilitating symptom of cancer. Palliative care is therefore crucial in providing holistic care for cancer patients. When pharmacologic therapies fail, interventional techniques play an important role. Thus, the need to make these more accessible, especially in the low-resource setting. Good afternoon, I am Mary Uy, and today I will present to you one such case. Our patient is a 33-year-old female who is a known case of a non-keratinizing squamous cell carcinoma of the cervix. She consulted for chronic intractable perineal and perianal pain. Her history started in 2019 when she was first diagnosed with the disease. She had completed her full course of chemoradiation therapy. However, there was noted tumor progression in the pelvic area. She was advised to undergo metastatic workup and another course of systemic chemotherapy. However, the patient was unable to do so due to the pandemic. She was reportedly well in the interim until the following year, she began to experience moderate pain on the perineal and perianal area. She consulted her local hospital, for which she was given a concoction of pain medications. However, due to financial constraints, she was unable to take all of them. In the interim, her pain severity progressed, now accompanied by generalized weakness affecting her activities of daily living, hence admission to our institution. On initial assessment, she described her pain as severe, continuous, crampy, vague at the perineal and perianal area, radiating to her pelvis and bilateral knees. She was unable to tolerate recumbent and sitting positions and would often be found in a lateral decubitus or prone knee to chest position. She was put on the following pain medications, however, it only provided the patient with mild relief and reported difficulty sleeping due to pain. She was diagnosed as a case of chronic malignant, mixed, nociceptive, and neuropathic pain secondary to squamous cell carcinoma of the cervix, with extension to the uterine, vaginal, parametrial, vesical, and rectal areas. Considering the poor response to medications, the plan for the patient was to do a ganglion impar block. The procedure was done in a rather unconventional prone knee to chest position, as this was the comfortable position for the patient. This technique is usually done under fluoroscopy guidance. However, due to limited availability in our institution, ultrasound was used instead. The area of the sacral hiatus was palpated and prepped, and the linear probe was placed longitudinally over the sacral hiatus. This was the imaging on the initial scan. The cleft caudal to the sacral hiatus was identified as a sacrococcygeal joint. To the left of the scan is a schematic drawing for comparison. The intervertebral disc in between the sacrum and the coccyx, located at the sacrococcygeal junction, was targeted. Local infiltration with lidocaine of the skin and subcutaneous tissue of the superior aspect of the intragluteal crease was done. A Quincke gauge 23 spinal needle was then manually bent about 1 inch from its tip to form a 25 to 30 degree angle prior to insertion at the SCJ to facilitate positioning of the needle tip to the curvature of the sacrum and coccyx. Using an in-plane approach, the needle was advanced until the coccyx was reached and walked transversely until the tip of the needle is observed to have reached the SCJ. 10 ml of 0.2 isobaric bupivacaine plus 40 milligrams of methylprednisolone was then administered in divided doses. 1 hour post-procedure, the patient was visibly more comfortable from a pre-procedural pain score of 10 out of 10 to 1 out of 10. She was able to tolerate recumbent and sitting positions. During the next 5 days post-procedure, her daily opioid requirements decreased with 0 rescue doses. The pain score was consistently at NRS 1 out of 10. 3 weeks post-procedure, the relatives noted marked improvement in the patient's lifestyle. She did not complain of any pain and was able to sleep more comfortably, even ambulating without assistance. Unfortunately, however, the patient expired 1 month after due to complications from her disease. So what exactly is ganglion impar? The ganglion impar is the ganglion of Walther is a solitary retroperitoneal structure formed by the fusion of 2 parallel sympathetic chains at the anterior aspect of the sacrococcygeal junction. It provides nociceptive and sympathetic supply to the following regions. This also forms a connection to the superior hypogastric nerve, providing coverage to perineal and pudendal areas. Ganglion impar block, therefore, is done on patients suffering from chronic intractable rectoanal pain with some pelvic pain. Initially, this technique involved inserting a bent Quincke needle gauge 22 blindly, targeting the skin overlying the anococcygeal ligament and administering local anesthetics, steroids, or neurolytics. This is done while performing a continuous rectal examination with the non-dominant hand to prevent accidental perforation of the rectum by the needle. While studies have shown it to be effective in providing immediate and lasting relief, the blind technique has been associated with high failure rates of 20 to 30%. Outcomes of this technique has been greatly improved by confirming needle placement relative to the surrounding structures using contrast dye and visualization under fluoroscopy or computed tomography. With an efficacy rate of 70 to 100% lasting up to 6 months, clinical trials and meta-analysis have shown that image-guided ganglion implant blocks effectively alleviates chronic intractable pain with fewer adverse effects. However, as presented in the case, these imaging techniques aren't readily available, especially in the low-resource settings. Hence, more recent studies have begun to explore the feasibility and efficacy of this technique under ultrasound guidance. Ultrasound guidance provides real-time and continuous imaging without exposure to radiation. Using this imaging also omits the need to palpate the patient's rectum, increasing acceptance and comfort of the patient during the procedure. An additional advantage is also the possibility of doing this procedure bedside. Limitations of the technique include limited view of the needle insertion depth, as well as the spread of the administered drug due to sacral and coccygeal bony artifacts. And this is further complicated by studies showing that the loss of a resistance technique to presacral space is not always reliable. To address this, an in-plane approach was used in the case to show longer needle trajectory. Furthermore, to ensure that the needle does not traverse the surrounding structures, the needle was walked transversely from the coccyx. These measures proved to be effective in avoiding inadvertent puncture of the surrounding structures, delivering safe analgesia to the patient. In conclusion, the patient presented in this case experienced 3 weeks of pain-free and improved quality of life prior to her eventual demise. Done properly, it has been shown that the ultrasound-guided ganglion implant block provides effective palliative care for patients experiencing chronic rectoanal pain. It effectively alleviates the severe pain, reduces overall analgesic needs, and thus associated side effects using high-dose analgesics. These are my references. Thank you for listening.
Thank you, Dr. Uy. May I now call on the next presenter for the case entitled Intraoperative Jet Ventilation in a Pediatric Patient with Subglottic Stenosis, a case report. Please welcome Dr. Katrina M. Ciego.
Good afternoon, everyone. I am here to present a case report on the intraoperative jet ventilation in a pediatric patient with subglottic stenosis. Subglottic stenosis is a narrowing of the upper airway that is often due to endotracheal intubation. Patients present with stridor, wheezing, and dyspnea as early as 3 weeks after. The presence of significant stenosis requires surgical procedures, which entail anesthesia that provides appropriate anesthetic depth with control of the airway. This case report details the successful anesthetic management of a 5-year-old female, JBA, who presented with stridor. 5 months prior to consult, the patient was involved in a motor vehicular accident, sustaining a 10-centimeter lacerated wound on the right temporoparietal area, with no associated loss of consciousness or vomiting. The patient was admitted at an ICU and intubated for 4 days. Post-extubation, the patient complained of hoarseness. She was discharged stable after completing antibiotic treatment for pneumonia. In the interim, there was noted dysphonia and stridor with hoarseness and occasional episodes of dyspnea, but without cyanosis or apnea. Consult at the local hospital was done, where she was initially diagnosed as having asthma. However, nebulization provided no constant relief. Flexible nasopharyngoscopy done on follow-up revealed subglottic stenosis, hence transferred to our institution for further management. On physical examination, the patient was seen active with O2 sat of 99% on room air. There was noted biphasic stridor, but with symmetrical chest expansion and good air entry. Other PE findings were unremarkable. At the wards, the patient was noted to have substernal, supraclavicular, and intercostal retractions, still with audible wheezing and stridor. ABG showed compensated respiratory acidosis with hypoxemia, hence hooked to O2 via nasal cannula at 2 LPM. Preoperatively, diagnostic blood tests done revealed normal CBC and bleeding parameters. Next, CT scan showed persistent narrowing of the subglottic airway at the level of C7 to T1, 0.2 centimeters in its narrowest segment seen in expiratory phase, while 0.5 centimeters in inspiratory phase with a length of 1.1 centimeter. The narrowest point is 2.8 centimeters from the notch of the thyroid cartilage. The rest of the airway is patent and midline in location. Initial diagnosis was upper airway obstruction secondary to post-intubation subglottic stenosis. The patient was scheduled for operation, stratified as moderate risk due to anticipated airway compromise perioperatively. An aesthetic plan was explained and consents were signed for the procedure. All pertinent airway equipment were prepared, including video laryngoscope with different sized blades, endotracheal tubes of varying sizes, both cuffed and uncuffed, as computed for age, and the manojet used for jet ventilation, which is then connected to the oxygen tank. Upon arrival at the operating theater, the patient was hooked to monitors, pre-oxygenated via face mask. Initial vital signs revealed the following. General anesthesia was induced by IV administration of midazolam, fentanyl, and atropine. Propofol infusion was also started. Initial intubation was done using a video laryngoscope with a pediatric D-blade. An uncuffed endotracheal tube size 3.5 with a ventilating bougie was inserted. However, it was unsuccessful. Bag mask ventilation was resumed, and on the second attempt, the ET tube with stylet was first placed through the glottic opening. The stylet was withdrawn, and the ventilating bougie was inserted through the tube until the level of the stenosis, where there was already noted inability to advance the bougie. The ET tube was then pulled out, while the ventilating bougie was secured and connected to the jet ventilator. This shows the patient's position after induction, with ventilating bougie secured and connected to the manojet. This gave intermittent bursts for oxygenation maintained at a PSI of 7 within the recommended dose of 0.5 PSI per kilogram for pedia patients. Anesthetic depth was maintained using TIVA with propofol at a rate of 10 milligrams per kilogram per hour and supplemented with IV ketamine doses of 0.5 milligrams per kilogram every 10 to 15 minutes. Intra-op findings showed 70% tracheal stenosis due to granulation at the right side of the trachea, 0.5 millimeters from the rima glottidis with thickness of 5 millimeters. Final procedure done was tracheobronchoscopy, DL with dilatation lasting for 1 hour and 20 minutes. Once the procedure was completed, jet ventilation was discontinued, end-tidal CO2 was increased, and ABG revealed respiratory acidosis with adequate oxygenation, hence supported with bag mask ventilation until the patient's emergence. The patient was transferred directly to the pediatric ICU, and pain was managed with paracetamol and nalbuphine. O2 was initially at 3 LPM and titrated down, and the repeat ABG was normal. The patient remained comfortable with no episodes of dyspnea or pain complaints, hence transferred to regular room on the second post-op day and discharged stable. Laryngeal insult is the most common cause of acquired subglottic stenosis, comprising 90% of these types of stenosis in children. Length of intubation is the most relevant factor in the development of these lesions, and also presence of simultaneous respiratory infection as in our patient who had pneumonia. Measurement of the patient's need for sedation as an indirect measure of agitation has also been provoked by friction between the tube and the airway mucosa. Once a definitive diagnosis of laryngeal stenosis is seen, patients may be treated endoscopically via the balloon dilatation, open neck surgery, or tracheotomy. Intraoperative airway management has been challenging for anesthesiologists, and standard techniques described include endotracheal intubation, jet ventilation, positive pressure ventilation via supraglottic device, and ECMO. In this case report, the patient underwent jet ventilation, where gas puffs are delivered under high pressure through a small catheter, creating an open ventilation system. This is used if procedures, especially when the presence of an ET tube would interfere with surgery, and it delivers oxygen bursts at a frequency of 10 to 14 per minute, allowing adequate time for exhalation via passive recoil of the lung and chest wall. Complications are due to high pressures of delivered gas and barotrauma. Hence, driving pressure must be adjusted to the minimum needed to achieve adequate chest expansion. Also, the degree of gas exchange, however, is unknown until end-tidal capnography or ABG is obtained. Airway surgery necessitates a deeper level of anesthesia for control of airway reflex, and fluctuations in hemodynamic parameters while also having enhanced surgical exposure. No muscle relaxant was used and spontaneous respiration was maintained to prevent further airway collapse. Incremental infusion of propofol was used for slow onset sedation and maintenance of spontaneous ventilation, and ketamine as an adjunct during maintenance was preferred so that respiration was maintained while providing analgesia. Procedures done in these patients require careful anesthetic planning to ensure ventilation and oxygenation of the patient while operating on the obstructed airway. Proper coordination and communication with the surgeon is needed, especially in the critical periods where surgical manipulation could compromise ventilation. Of equal importance, however, is the management of foreseen complications of the technique applied. Thank you.
Thank you, Dr. Shiego. Okay, for the last interesting case to be presented today, entitled Awake Craniotomy Using Dexmedetomidine and Propofol in a Medical Student with Oligodendroglioma, a Case Report. Please welcome Dr. Micah Alaisa Maduma.
Turn your scars into stars. I am Dr. Micah Alaisa Maduma, presenting a case report entitled Awake Craniotomy Using Dexmedetomidine and Propofol in a Medical Student with Oligodendroglioma.
Right, maybe we can start from zero timer. Thank you. Good afternoon. We would like to apologize for some of the technical problems that we encountered. Without further ado, I would like again to introduce the last case for this afternoon, awake craniotomy using dexmedetomidine and propofol in a medical student with oligodendroglioma, a case report. So let's welcome again Dr. Maika Alaisa Maduma.
Turn your scars into stars. I am Dr. Maika Alaisa Maduma, presenting a case report entitled Awake Craniotomy using dexmedetomidine and propofol in a medical student with oligodendroglioma. What would you do if during your medical internship, a doctor states you have a brain tumor?
Sabi ko, Lord, your will be done.
He said, Lord, your will be done. The patient is a 31-year-old male who complained of numbness and unusual twitching of right upper extremity for 5 years. 4 months prior to admission, he had partial tonic-clonic seizure with tremors with progressing duration. He was brought to a private hospital where MRI revealed a brain tumor. He was referred to a neurosurgeon, hence this admission. He is diagnosed with parasagittal mass frontal left to consider anaplastic oligodendroglioma. Planned procedure is temporoparietal craniotomy left, excision of parasagittal mass left with brain mapping. On preoperative evaluation, he is a 10-pack-year smoker with hypertension stage 1. He is overweight with BMI of 25.6. Physical and neuro exam are unremarkable. Diagnostics are essentially normal, except MRI reveals a 5.4 centimeter mass in the left frontal lobe. The patient is ASA physical status 2 malampathic class 1. Anesthetic plan is IV sedation with local anesthesia. It was explained to the patient and his family. Flashed is the preoperative evaluation form with consent. On the day of surgery, he verbalized anxiety without complaints of pain, BP 160-100, heart rate is 110. Midazolam IV was given and hooked to oxygen via nasal cannula. Standard monitors were placed with target BIS range values of 65 to 85 and Ramsey sedation scale at 2 to 3. Induction was started with propofol loading dose, then propofol drip as maintenance, and dexmedetomidine titrated to effect using a syringe pump. Scalp block at the incision and pin sites was done using lidocaine and bupivacaine isobaric plus epinephrine. A lumbar drain was placed thereafter. Mayfield application, craniotomy, and opening of the dura were performed while the patient was asleep. Picture shows the surgical field and the team.
This shows the neurologist doing a battery of tests. Propofol drip was maintained at a dose of 25 to 75 microgram per kilogram per minute. It was discontinued in between the surgery to awaken the patient during neurotest. Dexmedetomidine infusion was titrated to effect at doses 0.3 to 0.7 microgram per kilogram per hour. Moderate sedation was targeted and monitored via bispectral index. During brain mapping, there were episodes of generalized tonic-clonic seizures. Propofol IV boluses were administered, and we did not shift to general anesthesia, and the procedure lasted for 15 hours. Prior to transfer to PACU, patient was fully awake without complaints of pain and with stable vital signs. This is the summary of the medications given with range of vital signs, IVF infused, estimated blood loss, and urine output. The patient at PACU. No further seizure activity was noted until discharge on the 7th postoperative day. He was sent home without neurologic deficits. Histopathology result was low-grade glioma. After 5 months from his brain surgery, he passed the physician licensure exam and was featured at the Summit Express and television. 10 months after, MRI was unremarkable. Currently, he does moonlight duties in his hometown without neurologic deficits and dreams to become a neurosurgeon himself. The goal of awake craniotomy is to do wide tumor resection as safely as possible with mapping of areas responsible for sensory, motor, visual, and cognitive functions, and damage of which could cause permanent disability. Resection of brain tumor has high-risk complications. It poses unique challenges, especially for the anesthesia provider, who is faced with an unprotected airway and limited access to the patient due to positioning and pinning of the head. Advantages of propofol and dexmedetomidine. Propofol decreases CMR and reduces CBF. Dexmedetomidine does not cause respiratory depression and reduces anesthesia requirements. Propofol dose for IV sedation. Dexmedetomidine infusion rate. Anesthetic management of this case followed a traditional awake craniotomy. Patient factors to consider are good airway, appropriate weight, no history of GERD, and ability to willingness to cooperate. Further, we need a neurosurgeon known to be very skilled at performing this surgery, an anesthesia provider who is adept in doing the scalp block, paying keen attention to the needs of the patient and the surgical team. Our perioperative knowledge in neurocritical care, neuromonitoring, and neuroprotection is notable and irreplaceable, which made this endeavor a success. This is a journal wherein the surgery used pinless head support and avoided full scalp block in order to maximize the quality of the patient's experience using remifentanil and propofol. Dexmedetomidine is an alternative. These are the anesthetic considerations in this case. We use propofol instead of remifentanil due to its availability. It is cheaper but requires the skill of the anesthesiologist to balance sedation, analgesia, hemodynamics, as well as ventilatory control in an unprotected airway for a 15-hour procedure. Being careful to avoid excess sedation with a responsive, cooperative patient for neurologic testing intraoperatively. The use of IV anesthetics reduces the need for intensive care and the duration of hospital stay. In addition, dexmedetomidine and propofol are advantageous in reducing ICP and brain swelling compared to the vasodilatory effects of inhaled agents. IV anesthetics help increase CPP and decrease PONV compared with volatile anesthetics during craniotomy procedures. Therefore, complications due to general anesthesia are lower. Despite a plethora of studies that compare short-term outcomes using different anesthetic and analgesic regimens, randomized controlled trials that examine the long-term outcomes are of particular interest. In this pandemic of increasing burden on healthcare resources and lack of financial support, we must use techniques that are effective both clinically and financially. By passing the board exam, he is able to inspire others and spread the goodness of God. Truly, his scars turned into stars. Thank you.
Thank you, Dr. Maduma. Okay, now we will now proceed with the question and answer. Again, just like the first set, there will be one question each from the judges. So we start. May I invite Dr. Jamie Rose Mojica on the stage for her paper, Eventuation of the Diaphragm, Post-Arterial Switch Operation, a Case Report. May I start with Dr. Mariano?
Congratulations, Dr. Moica, for your presentation and successfully managing the case.
Thank you, ma'am.
Okay, but I got confused kasi yung title mo is Eventration of the Diaphragm Post-Arterial Switch Operation. But with regards to the eventration of the diaphragm, you only mentioned that the patient underwent plication of the left hemidiaphragm and tracheostomy under balanced general anesthesia.
Yes, ma'am.
Please elaborate on the anesthetic challenges that you have encountered during the plication.
Initially, ma'am, since the patient had already been intubated prior to the procedure, the patient already arrived at the cardiovascular OR intubated already. So what they did was, what was done during this procedure was just giving fentanyl and rocuronium boluses every around 30 minutes to 1 hour, maintaining the patient on both fentanyl and rocuronium, and ketamine was also given, ma'am, intraoperatively, and atropine. So the patient was just maintained on regular endotracheal anesthesia until the time that the patient was already due for tracheostomy, ma'am.
Okay, thank you, Doctora.
Yes, ma'am. Thank you po.
Thank you, Dr. Mariano. May I now ask Dr. Buen Suceso to give her question?
Afternoon, Doctora. Thank you for your presentation. The last paragraph of your case history stated the procedure done, which included tracheostomy. Tracheostomy was not part of the initial plan. It was just resorted to because the patient did not tolerate extubation. And then you said that the perioperative period was unremarkable. So can you still state that it is unremarkable, but after that you again said that the tracheostomy was done. You repeated that. So why did it seem that there were two tracheostomies that were done? Or was that just a typographical?
Let me just elucidate, ma'am. During the time that the patient underwent the arterial switch operation is when the patient was continuously intubated, even in the cardiac ICU. Now, when they had a failure of extubation, the patient was re-intubated, and then when they found out that the patient had eventration of the diaphragm, they then scheduled the patient for application of the diaphragm procedure. For this procedure, since the patient had already been intubated for more than 2 weeks, the effects or the complications of prolonged intubation was considered. Therefore, they decided to do tracheostomy along with the diaphragmatic plication surgery, ma'am. Thank you, ma'am.
Okay, thank you, Dr. Buen Suceso. May I now call on Dr. Duldulao?
Good afternoon, doctor, and congratulations for presenting this paper.
Thank you.
You have mentioned that extubation was attempted on the 15th post-op day, and patient was eventually reintubated due to the presence of deep intercostal and subcostal retractions.
Yes, ma'am.
Were these retractions evident immediately after extubation? And how soon did you suspect that there was left phrenic nerve paralysis?
Thank you, ma'am. During the time that the patient underwent trial of extubation, the pediatric cardiologist was the one who attempted this because they were already in charge of the care of the patient at this time. So after that, when they extubated the patient tolerated it for a couple of hours, but then soon after, the patient developed progressive desaturation and development of those retractions, which is why the pediatric cardiologist also decided to re-intubate the patient. And then that's the time when they decided to do a battery of tests that included an ultrasound and a babygram, and they found out at the time that the patient already had left phrenic nerve paralysis.
Okay, thank you, Dr. Mojica.
Thank you, ma'am.
Okay, for the paper, Anesthetic Challenges of Anterior Neck Penetrating Injury, a case report, may I call on Dr. Isabella Francesca BC. May I ask Dr. Buen Suceso to give the first question?
Just a comment. If you're familiar with the CARE checklist for case reports, you could have followed the guidelines so that your manuscript would have been clear. Like there's no need for including to your theoretical information like features of the pediatric airway. You should have concentrated on the uniqueness of your case report. Just a comment, no question.
Okay, thank you, Dr. Buen Suceso. Dr. Dulao, please.
Okay, same comment here. However, I still have some few questions. Wait. Okay, presented with this case, you were anticipating difficult airway. And so how did you prepare for this? What was your plan A and your plan B?
For our case, we opted to do IV sedations first po, but then we prepared for all of our setup just in case we need to convert to general anesthesia. So most of our airway devices and specialized devices are already prepared prior to the induction of IV sedation po.
And what was your plan B?
Sorry po, Doc.
I was asking if you have your plan A, then there should be a plan B and plan C. You should be planning for the unexpected, right?
For plan A, our original plan was to do IV sedation. Plan B is to convert to endotracheal intubation, which we did po nung we encountered oxygen desaturation intraoperatively po.
Okay, thank you.
Thank you.
Thank you, Dr. Dulao. May I now ask Dr. Mariano to give her question, please?
Okay, congratulations, Dr. C. And I gather that there was no sharing of airway during this procedure. And so, what is the duration of the airway maneuver where you have your two operators? And if there will be a loss of airway control at the point that the two operators, what is the rescue route and pathway?
It lasted for 15 minutes po. Oxygen desaturation lasted for 15 minutes. The original surgical plan was to do an invasive airway. Unfortunately, during the said procedure, they had a hard time identifying the structures and due to the airway manipulation, hence the desaturation. So we opted to do endotracheal intubation. For our case, there was no need for us to go to the emergency pathway for the difficult airway management algorithm po.
So you mean for 15 minutes, there are two operators?
There are two operators po.
Okay, so these operators are vigilant and
yes, po,
nothing happened, like hindi naman na bunggo yung kamay to the
No
point
naman
na
po.
displace yung
Hindi
tube.
naman po, Dr.
Okay, sige. Thank you, Doktora.
Thank you po.
Okay, thank you, Dr. C. May I call on Dr. Mary Uy for her paper Pain Demonium, a case report on the use of ultrasound-guided ganglion impar block for the management of chronic rectoanal pain. Okay, Dr. Uy. Now, may I ask Dr. Dulao for the first question?
Okay, congratulations, Doctor, again for presenting your paper. My question is, you asked your patient to come back supposedly after a month, right, for follow-up. And what was your expected duration of pain relief?
For this technique po, ma'am, it usually lasts for 4 to 6 months po. That's why we follow up with our patients monthly po, or more often if they have other concerns po.
Okay, thank you.
Thank you po.
Thank you, Doctora. Now, may I ask Doctora Mariano to give her question, please?
Okay, Doctora Uy, we share the same interest in pain. Okay, so first of all, I would like to comment on the picture where the bat was showing. You should put there with permission from the patient. Did you ask permission to?
Yes po, ma'am.
Oh, so it should be placed there, no? And my question is, if ganglion block is not done, what do you think is the problem with the pain management and how will you correct it? Because the patient is being given paracetamol, gabapentin, fentanyl, transdermal patch, oxycodone controlled release, and oxycodone immediate release. And there were 10 rescue doses per day.
It could be po, ma'am, that they have not been titrated, the dose of opioids have not been titrated properly. Also, considering the type of pain that the patient was experiencing, so it's it needed also the patient also had neuropathic pain, so probably the dosing was not we haven't found the right dosing to address that also po.
Okay, that's correct, no? If you have incorrect dose of the medication, syempre magkaka-pain. And another problem is that when you, for example, you're correct, you have to titrate. When you have to increase the dose of your opioids, the one you're giving for baseline or background pain, this is either the round the clock or the continuous opioids. When you increase that, you also have to increase your rescue medication. Yes. So the problem is often that it's only the background medication that is increased. So when the patient has pain, the rescue medication is not adequate to relieve the pain. Okay, that's all. Thank you.
Thank you, ma'am.
Thank you, Doctora Mariano. May I call on Doctora Buensuceso, please?
Good afternoon, Doctora. Thank you for your presentation. My question is, what are the other agents that may be used for this type of block?
Sorry,
besides the ones that you used?
Sometimes po, other studies have used different types of adjuncts, so very similar to our other regional techniques. So some would use clonidine, dexamethasone, dexamethasone, even neurolytics po, depending on the goals for the patient.
Are those included in your review of literature, published literature?
Yes po, ma'am. Some studies have used also phenol, alcohol for.
So why did you choose, you use bupivacaine and a steroid, so why that choice?
A big factor was the availability of the medications po. So in our institution, those two were the most accessible and easily provided for the patient.
Okay. Thank you, Dr. Uy. Okay, may I call on Dr. Katrina Ciego for her case presentation of intraoperative jet ventilation in a pediatric patient with subglottic stenosis, a case report. Dr. Mariano, can you give the first question?
Okay, so the patient had compensated respiratory alkalosis.
Yes, Dr.
What is the ABG picture of compensated respiratory acidosis?
Patients who have compensated respiratory acidosis, Doc, these are those that have decreased ventilation, hence they have hypercarbia, Doc. Thank you.
Aside from hypercarbia, what are the other things that you have to look into the ABG in order for you to say that your patient has compensated respiratory acidosis?
For patients, Doc, who have, aside from hypercarbia and the ABG, we also check for the oxygenation of the patient, the level of the oxygenation. And for this patient po, it is within normal also.
So aside from the hypercarbia, you have to check the pH,
Yes, Doc, sorry, the first one.
bicarbonate,
It's the first
and the
to
base
check.
excess. Okay,
Yes,
thank you, Doctora.
Thank you, Dr. Mariano. Dr. Buensuceso, please.
Just a comment, when I was watching your video, I noticed that the structure surrounding the glottic opening were very red, yung mucosa. Was that just because of the settings of the CMAC, or
Yes po,
was
Doctor, it was
the
only because
hyperemia, or hindi naman mukhang bleeding?
there was no bleeding, Doc. It may only be because of the video also. During when we see it in the laptop, Doc, it's a bit clearer po and whiter.
Okay. No other questions.
Thank you, Doc.
Thank you, Dr. Buensuceso. May I call on Dr. Duldulao?
Yeah, thank you, Doctora, for your presentation. My question is, what is the most dreaded complication that you were thinking in doing such technique, and how did you prepare, and how would you manage for that complication?
For this case, Doc, since it is an example of a shared airway procedure, we were preparing for, if you were able to see, Doc, the procedure was for possible tracheostomy. So while we were trying to insert the ventilating bougie for the intraoperative oxygenation and ventilation of the patient, the airway team, especially the ENT surgeons, were present, Doc, along with us. And of course, the most dreaded complication for this procedure is not being able to ventilate the patient during the procedure itself. Thank you, Doc.
Thank you, Dr. Duldulao. Thank you, Dr. Ciego.
Thank you.
May I now call on Dr. Maika Alaisa Maduma for her for her case, awake craniotomy using dexmedetomidine and propofol in a medical student with oligodendroglioma, a case report. May I start with Dr. Mariano?
Okay, congratulations, Dr. Maduma, for your paper. Now, during awake craniotomy, communication is very important. So you agree with me. And during the pre-op and the actual surgery, how did you communicate with your surgeons? And the patient also.
Good afternoon, ma'am. Thank you for that question. For the neurosurgeons, ma'am, prior to the procedure, we asked how is the position of the patient during the OR, and what medications do they prefer, and we also discussed the medications that they want to use, like the remifentanil is not available in our institution, and we are just using the resources available, like the syringe pump instead of the infusion, which is actually the ideal setup, and with that, we're able to discuss what are the preparations, the preference of the neurosurgeons. And with regards to the patient, ma'am, prior to the procedure, we explained to him very well that while operating, there are times that we will stop the medications, and the patient will wake up with the surgical team beside and around him. So he must be fully cooperative and be able to endure the stress of the long procedure. So we emphasize on that, so that during the procedure the patient is fully prepared. And also we explained the risk, and if he has
questions were just beside to assist him during the whole procedure po, ma'am.
Okay, thank you, Dr. Maduma.
Thank you, ma'am.
Okay, can I ask Dr. Duldulao to give her question?
Thank you, Doctora, for presenting your case also. My question is, why is there an emphasis on mentioning that the patient is a medical student? Would it be different? Would the management be different if your patient is not a colleague or a non-medical student or any other patient?
Good afternoon, ma'am. Thank you for that question, ma'am. The patient is a medical intern, so prior to the procedure, he have plans to take the board exam, and as a medical student, he is also aware of the risk of the surgical procedure, and so it is unique in this case because there's only small cases or even no reported cases yet of medical students being operated for brain tumor with this kind of surgery. And with that, the patient the patient have a leap of faith in doing this procedure po, ma'am. Thank you, ma'am.
Okay, thank you, Dr. Duldulao. May I call on Dr. Buen Suceso, who was the first judge to give the first question, and now will be the judge who will be giving the last question.
I have a very similar comment to the comment of Dr. Duldulao, because the uniqueness of the case is not because the patient is a medical student. In fact, one of the things that the ethics boards looks into is that the patient should be unidentifiable, and anonymity should be preserved. You even had pictures in your manuscript. There were no covers for the eyes, but in your presentation, one picture had a cover and another wala na naman. So it's very important. Even if you had consent, that's one of the things that should watch out for case reports. The patient should not be identifiable. Ethical
Yes,
concern.
ma'am. Thank you, ma'am. Ma'am, we also tackled on that, ma'am, but the patient was presented at Summit Express and televisions, YouTubes. So at the first part, I covered them and they were unidentifiable, but during the last part of my slides, ma'am, that's the time I have revealed the patient po, ma'am. Thank you, ma'am, for that comment, ma'am. Thank you.
Okay, thank you, Dr. Buen Suceso, and thank you, Dr.
ma'am.
Maduma.
Yes, ma'am.
Actually, I agree with that, no? Especially with the presence now of the data privacy law. So we should all be careful with how we deal with tackling and discussing the cases of our patients. No? Thank you, Dr. Maduma.
Thank you, ma'am.
Before we proceed to the distribution of certificates, I would like to acknowledge and recognize the PSA CME Subcommittee on Interesting Case Contest for their hard work and dedication in and diligence in choosing the best among the best of the interesting cases that were submitted to the PSA. Okay? So we now proceed with the distribution of certificates. May I call on the chair of the CME, Continuing Medical Education, Committee of the Philippine Society of Anesthesiologists, Dr. Carl C. Su, and the chair of the PSA CME Subcommittee on Interesting Case Contest, Dr. Pena Francia Cano. to award the certificates of appreciation. And I read, the Philippine Society of Anesthesiologists presents this certificate of appreciation to the following as participant during the PSA 30th Interesting Case Contest oral presentation, given this 23rd day of October 2021, signed by Dr. Pena Francia Cano, PSA Vice President and Chair of the Interesting Case Contest 2021, Dr. Carl Matthew C. Su, PSA Board Director and Chair of the PSA Committee on Continuing Medical Education. So we start first with Dr. Michael Ryan Manera for his paper, A Case Report on the Airway Management of a Pediatric Patient with Ankyloblepharon Ectodermal Dysplasia Clefting Syndrome using two-stage styles technique. May we ask Dr. Manera to go up the stage, please? Can you give a wider view? Parang yan better. Okay, the certificate of Dr. Gira Gail Baluga will be sent to her, okay, personally. So may I call on Dr. Jordan Carl Pervera for his interesting case. Contents of the certificate is the same, including the signatories. May I call on Dr. Jacqueline Pardo. Dr. Matthew Marion Kang. Dr. Jamie Rose Mojica. Dr. Isabelia Francesca C. Dr. Mary Uwi. Dr. Katrina Ciego. Dr. Maika Alaisa Maduma. Dr. Manera. All right, that was fun. Before I let my officers here go down, I would like to call on our chairman of the Board of Judges to be awarded their certificates. By the way, the certificate of Dr. Buen Suceso and Dr. Duldulao will also be sent to them. All right, may I call on Dr. Zenaida Mariano. And the certificate reads, the Philippine Society of Anesthesiologists presents this certificate of appreciation to Dr. Zenaida Mariano as chairman of the Board of Judges during the PSA 30th Interesting Case Contest oral presentation given this 23rd day of October 2021, signed by the same signatories, Dr. Penafrancia Cano, Dr. Carl Matthew Sisu, and Dr. Edgard Simon, President of PSA. Dr. Ben Suceso and Dr. Duldulao, can you kindly face the camera po kasi included kayo sa picture ng Board of Judges. Okay, in case Dr. Jira did not hear her name, but I actually mentioned, di ba, after Dr. Manera, I mentioned that her certificate will be sent to her for her paper retrograde intubation in patient with oral squamous cell carcinoma case report. I will repeat the name, Dr. Jira Gail Baluga. Doktora, tinawag kita kanina. It was just that we were not able to show your beautiful face.
Okay po, Doc. Thank you po.
Okay, so thank you, Doktora, also. And good luck and congratulations na rin because all of you are winners already.
Thank you po, Doc.
And now, For the most awaited moment of this contest, di pa si Dr. Mariano ang mag-a-announce, kaya siya yung may drum roll. I would like to call the chair of the Board of Judges, Dr. Zenaida Mariano, to announce the winners of this year's interesting case contest.
Okay, a pleasant and exciting good afternoon to Dr. Pen Cano, PSA Vice President and Chair of the Subcommittee on Interesting Case. Also to Drs. Johnny Serrano, Carl C. Su, and Salvador Brodit. I would like to thank the PSA for giving me this opportunity to be with you this afternoon. My congratulations to the mentors of our presenters for guiding you until you reach the finish line, and for the presenters for being able to share their difficult cases and, of course, successful management. Remember, to our dear presenters, that you belong to the top 10, and that makes you a winner. But today, we will answer the question, who will be the first 3 winners or the first 3 positions? Okay, before we answer, just to keep the excitement, I want to give some comments on your case report. I did not ask you this whenever you report kasi the next reporter will already be able to prepare the answer, and it will be unfair to the previous reporter. So my comments are, you have to improve on your referencing. Usually we use the Vancouver since this is a scientific paper. You have to put the in-text citation and the references, and they must be consistent. Kasi yung iba, their in-text citation is number 1, then number 6. So since this is in number, it should be followed by number 2. So I guess for those papers who did that, it gives the judges the impression that it was copy-paste, okay? So wag niyo masyadong ipahalata, okay? Most of the case reports have more than 10 pages. So the challenge for you presenters is to convert your 10-page case report to 2 to 3 pages, kasi that's the only number of pages allotted for you in journal publication. In some journals, they only allot 1 page. If you will require more than 1 page, you have to pay for it. That's for international. So you can publish with us in the Philippine Journal of Anesthesiology. Number 3, the consent must be described, particularly in children. And this was the question of Dr. Buensuceso. So I noticed that the presenters are quite shy. They refrain from eye contact. Maybe they're afraid that I will see them and ask them more difficult questions. And of course, there should be no use of collegial terms like moonlighting, because if you publish your paper in an international journal, they will not understand what is moonlighting. But for us Filipinos, alam natin kung ano yon. Okay, eto na. Dandarandan. Ay, nawala ko yung papel. Okay. So, drum roll. Okay. Parang hindi naman pang-winner yan. Parang si Dracula ang darating. Okay. So,
Dr. Mariano, excuse me. Pang-prolong lang ng agony. May I request already, Dr. Pen na Francia Cano and Dr. Carl Sisu and Dr. Brodit to please come up the stage so that when Dr. Mariano called the winners, they can go up immediately and claim their prize. 50% will be mine and 50% will be yours.
Oh, how about me, Johnny?
Doktora, mayaman ka na. Okay ka na po.
Okay, for the 3rd place. Okay. The name has a letter A. Sino ba may letter A dyan? Lahat ba? Pero parang sa brain yata to. Kasi, hindi, sa labas. Kasi extracranial eh. For the third place, it goes to Dr. Jacqueline Pardo for the case report entitled Anesthetic Challenges in Open Repair of Extracranial Common Carotid Artery Aneurysm, a case report. Congratulations, Doctora. Picture. I would like to remind the PSA Secretariat not to post this in Facebook. Bakit? Walang social distancing, walang face mask, okay? Face shield. Showbiz. Okay, so baka makita ng mga anak ko, magalit. Okay, for the second place. Okay. So ito naman may letter E. So, airway management. Sino nag-airway management? Marami, ha? Pero sa bata. So, a case report on the airway management of a pediatric patient. Naku, ang hirap basahin ito. The ankyloblepharon ectodermal dysplasia clefting syndrome using two-stage Stills technique. May I call on Dr. Michael Ryan A. Manera. Okay. Anong hospital? From UPPGH? Yung kanina. Okay, so Dr. Manera is our second winner from PGH. Ano? Herd immunity na tayo. I heard. Okay, sige. I heard you. Okay, sino kaya ang winner? Matanda ang pasyente? Hindi. Hindi matanda ang pasyente. So may letter I naman ngayon. So, sino ang mga pedia patients dyan? Okay, for our first prize, garnering a score of, wala less than 100 siguro. Okay. For the intraoperative jet ventilation in a pediatric patient with subglottic stenosis, a case report, may I call on Dr. Katrina M. Shiego from St. Luke's Medical Center.
Audio Jungle.
Congratulations to the winners. Okay, so for the third, second, and first prize, I will be waiting outside for you. I'm going to sign your envelope. By the way, all the remaining papers will have a consolation prize of how much, Doctora? 5,000 pesos. So it will be given to you directly by the chair of the subcommittee on interesting case contest. Wala ba yung MC? Anyway. All right, it is indeed a very fruitful event and a fitting finale for our Anesthesia Week. And to give the closing remarks, please welcome one of our board director. She was a past president of the Society for Obstetric Anesthesia of the Philippines, former chair of the Department of Anesthesiology of St. Luke's Medical Center, Quezon City, and an anesthesiology consultant at St. Luke's Medical Center, Global City. Please welcome Dr. Irma Montecillo.
Thank you, Johnny, and a pleasant afternoon to all our fellow anesthesiologists. And indeed, it was a very exciting afternoon, especially for our presenters of the interesting case. So as you all know, we have this yearly interesting case contest, which falls on our Anesthesia Week. So as mentioned by Dr. Ed Simon earlier, this ends our Anesthesia Week celebration for this year. And I hope that you enjoyed and gained something from the different webinars that we presented for the past week, either anesthetic and non-medical topics. And as mentioned earlier also, because of the 70th year anniversary of PSA, we added the prize for the winners for this afternoon's interesting case contest. So again, congratulations to the winners, and hope to see you all on our annual convention this coming December 3 to 5, 2021. Okay, so again, congratulations and have a good night. Thank you, everyone.
Thank you, Dr. Montecillo. In spite of the coronavirus pandemic, we continue to enhance and upgrade our knowledge to better serve our patients. May today's event encourage our residents and colleagues to become better in our practice of anesthesiology and to be generous in sharing their knowledge and experiences in the future. Stay safe, everyone. Stay healthy, and see you during the annual convention. Good afternoon and good night. May we request all the participants to come here for a group picture. Syempre with social distancing, please. Yung winners daw muna. Yung tatlong winners daw muna.